IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its cause shall be our cause. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the committee of nation. Jai Hind, Jai IMA.
Next, we have welcome speech by Dr. Noufira, Assistant Director, CGP.
Respected IMA President, Dr. Sandhya Kurup, Dr. Chandni Madam, the moderator for today, Dr. Anish TS, Nodal Officer of the Nipah Research and Resilience Center, Dr. Ranjith, Branch Secretary, Dr. Jithin, all our panelists, distinguished IMA senior and junior members, and also those who are watching this program online. Very good evening to all. This month we have come up with a very very important topic, because in the recent years the word Nipah has sparked understandable concern across our communities. However, history and science have shown us that the most effective antidote is not silence, it is information. So today we have gathered a distinguished group of experts to peel back the layers of misinformation and provide us with the clinical, social, and preventive truths about this virus. So, the Nipah One Health Research and Resilience Center, under the able leadership of Dr. Naveen and Anish TS sir, they have joined hands with IMA CGP to bring insights into the understanding of Nipah, to reduce the response time to this pandemic, and also to unveil the truths and behind this Nipah. So on behalf of CGP, first of all, let me welcome our branch president, Dr. Sandhya Kurup, to this function. Next, may I extend a warm welcome to Dr. Chandni Madam, Principal of GMC Wayanad. She's also the moderator for today. Madam. Now let me invite Dr. Anish TS, Nodal Officer of Nipah Research and Health Resilience, to this program. Dr. Ranjith, Dr. Jithin, and our panelists, other panelists for today, Dr. Naveen, he is the state head of the CDC, Kerala, and Dr. Anitha PM, HOD of Department of Microbiology, Dr. Shamir, Associate Professor, Department of Medicine. I extend a warm welcome to three of them. And we have also Dr. Shaji. I think he's coming for the first time to, he's a member of Mulangunutkavu IMA. So he's a HOD of biochemistry. I extend a warm welcome, and also all the members who have joined here for today. So let's move on to the, all those who are watching this program online also, I extend a warm welcome to all of you. Thank you.
Presidential. Respected Chandni Madam, Dr. Anish, Dr. Ranjith, Dr. Noufira, Dr. Jithin, and all panelists of today, Dr. Shamir, Dr. Anitha Madam, Dr. Naveen, and all dear IMA members, and all members who are watching this YouTube. A warm good evening to all. Now we are going to have an important panel discussion about Nipah. Nipah, clinical red flag signs and resilience. So, IMA in association with one center for clinic Nipah, we are conducting it. First of all, I must thank Dr. Chandni madam, my own teacher. She has traveled from Wayanad Medical College and to Kozhikode, and she has reached on time. And she is the moderator for today's function. And Dr. Anish, and now, as we all know, Nipah is Nipah is not an emerging infection, but it is a reality. We all have witnessed it. So, as you all know, Nipah virus infection in our state has repeated outbreaks, each time reminding us flag sign is often seen by physicians. So, as physicians, we should know what are the clinical signs and symptoms and how we manage it and how we tackle the important aspects of the disease. And we all should know that. So, I must congratulate Dr. Noufira and Dr. Jithin for taking this topic and for this program. So, this discussion is especially significant because it bridges the entire spectrum from bedside clinical recognition and infection control and to public health prospectus and intersectoral coordination and global resilience. So, as medical professionals, we are not only caregivers but also sentinels, educators, and advocates for evidence-based policy. So, here one more thing I have to say, that our membership campaign, they are giving membership at a reduced rate till March 15th, and I request all doctors to be a part of this national organization IMA. And the second thing is, be a part of all schemes of IMA, especially professional protection scheme, health scheme, all social security schemes, and all disability schemes. So, the other thing is, on coming Friday, on 13th, we have a dharna in front of our collectorate from 11:30 to 1 o'clock. And I request all of you to be a part of it. This is just to correct or rectify the mistakes in Clinical Establishment Act. So, I request all of you to join for the same, and I think I am not going further. I once again welcome all the panelists for this program, and I thank all of you for coming here. And now we will move on to the next program, that is Minutes of Last Meeting by Dr. Jithin, Secretary IMA CGP.
Respected Branch President Sandhya Madam, Chandni Madam, Anish Sir, Ranjith Sir, Noufira Madam, Senior IMA leaders, members, the panelists of the day, and all the online viewers. The last session of CGP, that was in the month of January 2026, was conducted on 14th January 2026, Wednesday at 7:30 p.m. at IMA Hall, Kozhikode. It was a session on various orthopedic topics by speakers from Aster Ortho Specialty Hospital, Kozhikode. The program started with IMA prayer and flag salutation by Dr. Vishnu K, Joint Secretary IMA Kozhikode. Dr. K. Sandhya Kurup, President IMA Kozhikode, presided over the function. Dr. Noufira P, Assistant Director IMA CGP, welcomed the gathering. Dr. Jithin, Secretary IMA CGP, presented the minutes of last meeting. The first session was on Introduction of Foot and Ankle Department at Aster Ortho by Dr. Lulu Damsas Pulakundan. The second session was on New Age Trends in Joint Replacement by Dr. Mohammad Hassel M. The final and third session was on Approach to Lower Back Pain by Dr. Siad Ahmad PP. All the sessions were very interesting, informative, and interactive. All the speakers were felicitated by office bearers and senior IMA members. Dr. Jithin delivered vote of thanks. Around 55 of our members attended the session. The session ended by 9:10 p.m. and it was followed by dinner. Thank you.
Next, we are addressed by Nodal Officer, Dr. Anish, sir.
Respected Chair Sandhya Madam, Noufira Madam, Chandni Madam, Dr. Ranjith, Jithin, respected senior doctors, dear friends. I am standing here on behalf of Kerala One Health Center for Nipah Research and Resilience. Dr. Naveen is also working with me. And we are just visualizing this event as a very important one, because this is one opportunity that we can communicate to the doctors who are working in the field. Because we know that Nipah is a reality and Kozhikode is one of the hotspots of Nipah. And for the last maybe 5 years, we don't have outbreaks. Maybe for 3 years, not 5 years, 3 years we don't have outbreaks, but still we are maybe there is a good chance that we are going to get an outbreak maybe this year. Because if you just look at the pattern, every year the number of spillovers are increasing. Is it maybe because we may be detecting more number of cases? If you just ask me, which year we reported most number of Nipah spillovers is 2025. Out of the 10 spillovers that happened in Kerala, the 4 reported last year. That means every year the spillovers are increasing. Luckily, it is not translated to outbreak. The human-to-human spread is much less nowadays. But still there is a chance. Maybe usually Nipah, we may be knowing that there is a chance of a hospital-based super spreading, where the doctors, nurses, and maybe patients may be infected by Nipah virus. That is the one of the pathognomonic feature of a Nipah outbreak. A hospital and health workers may be involved. So we will discuss all these things in the panel discussion. And we are just, I wish all the best to this meeting. And this meeting is very important for us as an organization which is aimed to build resilience against Nipah. Thank you.
Next, introduction of the speaker by Dr. Noufira, Assistant Director of the MCG. Introduction of the moderator, Chandni ma'am.
We are indeed honored to have Dr. Chandni Madam as the moderator for today. She is the principal of Government Medical College, Wayanad. She won the Best Doctor Award, Government of Kerala, in the year 2018, and also the Best Teacher Award in the year of KUHAS 2019. She has also won the National RSSDI Women Diabetologist Award 2024. And she also won the prestigious Women Physician of the Year Award, American College of Physicians, India Chapter 2025. And she has also received the Certificate of Appreciation for the Nodal Officer to Control Nipah Epidemic in Kozhikode, Government of Kerala 2018. She is also the State Expert Committee member of COVID-19. She is also the chairperson of Kerala State Medical Board, COVID and Nipah, also the chairperson of IEC of Enhanced Kozhikode and the member of IECs of other institutions. And she's also the national governing body member of Association of Physicians of India. And her association with IMA is she's a former assistant director of IMA CGP Kozhikode, also the member of the Kerala Medical Journal, editorial board and IMA Research Cell 2023-2024 and 2024-2025. She's also the fellow of IMA Academy of Medical Specialties 2017 and also the recipient of the prestigious Dr. P.A. Alexander Memorial Oration 2022 of IMA. And she's a stalwart in the healthcare 2018-2019 from WIMA. So, ladies and gentlemen, presenting you Dr. Chandni.R, our moderator for today.
I invite all panelists to come on stage.
Good evening, respected teachers, seniors, and my dear appreciation from us because he was working hard on those days. And we know that Nipah 2018 was a story of resilience and regional adaptability. And then we have moved on to many outbreaks and spillovers. All happened in 1998, 99 in Malaysia, Singapore. But we started seeing this quite unexpectedly from 2018. It's a virus that is causing small outbreaks or spillovers. But the world is looking so much into this Nipah. Why? Because this outbreak, as in COVID-19, may become some variants and future it might become a milder infection. But it's also very possible that it may increase the virulence and become something like a pandemic. That's what scares everybody, Nipah X. But more so, Nipah is a disease with high mortality. And we know that the survivors, at least 3, are having significant morbidity. It was a disease with high mortality, significant morbidity, and so much of pressure on the system at that point of time. So we have with us all the experts that we can gather today. And I am very happy and proud to introduce the persons, doctors who are participating in this. So this is the program, and we have Dr. Naveen, Dr. Anoop, Dr. Anitha, Dr. Shamir, Dr. Anish, and I will introduce, but I can speak 1 hour on each of them. I had long association from 2018 with all the outbreaks. Dr. Naveen Anaswara was part of the 2018 outbreak as Nodal DPM, and that way he has contributed significantly, but he became an asset to the Kerala government and all of us after he has attained MPH from Johns Hopkins University. And currently he is the state project head, Kerala CDC, and awards and honors, Fulbright Nehru Scholar 2023-2024, something really big that he has achieved. Hearty welcome, Naveen, to this session. And with us, Dr. Anitha PM, Professor and Head, Department of Microbiology. And I think the maximum number of phone calls goes when any AES, ARDS happens anywhere in Kerala or outside. And always pleasant, receiving all the calls very patiently and calling back even when we misses a call. So that was the commitment she always shows. And she has done so much of work, not only in Nipah, but in many other things that we have been seeing in all these days. And she has got the Appreciation Award from Health Minister Veena Ma'am on her services rendered during Nipah outbreak, and she has received Best Doctor Award from KGMCTA in 2023. And with us, Anitha. And with us, Dr. Anoop Kumar. Yes, and he was part of the strongly with the first outbreak, and he has managed many patients at that point of time. He was in BMH at those days, and he is currently director Aster North Kerala cluster. He's the critical care specialist, and he was recognized for the early detection of the outbreak in Calicut 2018, and his subsequent role in containment activities. And he is winner of the Best Doctor Award of Kerala Government, Kairali TV Best Doctor Award, and many others to his credit. Welcome, Anish, Anoop. And with us, Dr. Anish. He is Professor and Nodal Officer, Kerala One Health Center for Nipah Research and Resilience, Kozhikode. And he is the most sought after person. If you want to have anything related to many things, I always ask his help. He was an expert with the expert committee member of COVID-19. In fact, Anoop was also there during that time. So he has contributed immensely, not only in Nipah, but in many research activities, and he is also into the disaster management of Kerala state. I don't know what is your role, but he was contributing immensely in that way also. And Shamir, I think, known to everybody, is associate professor, most passionate teacher and most sought after teacher among MBBS and MD students of Calicut Medical College and other colleges as well. He was assistant nodal officer. Maybe maximum phone calls I used to do, and always I prefer Shamir there in the team. So Shamir may be angry with me. I suggest whenever an outbreak comes, I suggest, Shamir, put Shamir into the group so that we all feel bad. So I have all the team here, all very much real practical experience in Nipah outbreak management, and we are going to listen, and we'll have 10 minutes presentation so that we know what they have to tell, and we will have an open forum. We'll take questions from you as well as I can also ask questions. So we'll start with the presentation by Naveen, Nipah virus and emerging global health threat.
Thank you, Chandni Madam, for the nice introduction. And respected teachers, friends, today I'm going to deliver a presentation on introduction to Nipah virus, and I have only 8 minutes in hand. So I am going to discuss some details about the Nipah virus and how it's going to be an emerging global health threat. So in this poster you can see it's a time for Nipah Jagrada. From April to September, all cases of Nipah cases in Kerala were reported in this months. So we are going to face another Jagrada Kalam, April to September. So about the virus, it emerged in 1998 during an outbreak among pig farmers in the village of Sengai Nipah in Malaysia. That's how the name Nipah came for the virus. And it's a paramyxovirus with a non-segmented negative sense RNA viruses So it's very it's capable of having mutations easily. And the genus is Nipah virus, Nipah. Many viruses are there in Nipah family, like Hendra virus, which affects horses, especially in Australia, in Queensland. And the incubation period generally ranges between 4 to 21 days. It's also important. That's why we tell people to be in quarantine, contacts in quarantine for at least for 21 days. And another important thing is it can survive for up to 3 days in some fruit juices or fruits at local environmental temperatures. It can remain infectious for at least 7 days in date palm sap kept at 22 degrees Celsius. The virus has a half-life of 18 hours in the urine of fruit bats. However, it can be completely inactivated by heating at 100 degrees Celsius for more than 15 minutes. And the receptors, Ephrin B2 and Ephrin B3, these are the receptors to which virus particles they are attaching, and it's very, very important. And it's universal in so many vertebrates. So many vertebrates can be intermediate hosts during Nipah infection. So that information is also very important. And the timeline, it started 1998 in Malaysia in pig farmers, 1999 in Singapore, and it actually it's abattoir workers exposed to the virus when handling pigs. And in Bangladesh from 2001 onwards, in most years, spillovers were reported in Bangladesh and in India also, in the borders of Bangladesh, in West Bengal, 2001-2007. And unfortunately in Kerala, in 2018, the Nipah outbreaks happened, and nearly 10 spillovers happened in Kerala, and 2 went to outbreaks, and all 8 ended up with single cases. And another country is Philippines. In 2014, the intermediate host were horses in Philippines. So this is a timeline of Nipah virus infections globally. And the natural reservoir is Pteropus species fruit bats, Pteropus medius, and Rosetus species also. And nearly 12 bat species were recognized to have Nipah virus. And you can see in the map the Pteropus species, their home range extends from the South Pacific Islands in Australia through Southeast and South Asia to Madagascar. So it's a wide range. So countries in this area all are susceptible to Nipah virus infections. And 2 clades, 2 varieties of Nipah viruses have been reported. Clade 1, it's Bangladesh and Indian clade, and clade 2 is Malaysian. Genetic classification, Kerala variant genetically close to clade 1. It's not exactly like clade 1, but nearly 90% is similar to clade 1. And clade 1 is high case fatality rate, more than 70%. And clinical presentation will be encephalitis with severe pulmonary involvement, with common respiratory symptoms, and higher likelihood of human to human transmission, and it is more pathogenic, and the viral load in secretions are high, and incubation period is shorter, and mortality rate is higher. So unfortunately, the Nipah virus in Kerala is in clade 1. Coming to transmission, you can see the picture. To animals, the transmission is by the consumption of contaminated fruit with saliva or urine from infected fruit bats, or the consumption of meat from an infected animal. For direct contact with other infected animals, rectal shedding of viable virus was reported in animal models. And to people, by direct contact with infected wild or domesticated animals, or their excretions and secretions such as urine, saliva, blood, pharyngeal and respiratory secretions. And the possibility of aerosols, transmission through aerosols should also be considered. Consumption of unprocessed meat from infected animals or unheated raw food products that have been contaminated by body fluids of infected animals such as palm sap or fruit contaminated by an infected fruit bat. Contact with the body fluids of an infected person such as nasal respiratory droplets, urine and blood. So in Bangladesh, the transmission was reported especially through consumption of raw date palm sap, and in Malaysia and Singapore through pigs, in Philippines in horses, and mainly clade 1 there are no intermediate hosts, only clade 2 have intermediate hosts. So in Kerala, no intermediate hosts have been reported. So it's risk group 4 pathogen, and WHO considers Nipah virus infection and related Nipah viruses as priority pathogens because of 4 reasons. First one is broad geographical range that we have discussed already, and the wide range of animal species they can infect, especially due to the presence of epherin receptor, a propensity to regularly spill over to human populations, and a high case fatality rate from infection. This is a poster created from our side. Just we made some IECs, and we conducted an IEC workshop, and we collected these concepts from the field, and we made some posters, and it will be released. It has been released by Health Minister, but we will release to the field soon. So WHO Southeast Asia Regional Strategy for Prevention and Control of Nipah virus infection 2023 to 2030. So after 2018's Nipah virus outbreak in Kerala, WHO accorded the highest priority as a regional threat, and it's organized an expert consultation on NIV in October 2019, and they have made this strategic plan 2023 to 30. The vision is to prevent NIV illness and death within human populations in the Southeast Asia region by 2030. And it is aligned with the national strategies, national emergency strategies. Under the headings preparedness, it's giving importance to socio-ecological aspects, and strengthen policy strategy, and ensure multi-sectoral health system, strengthen multi-sectoral health system capacity, risk communication, R&D, research and development. Coming to prevention, behavioral changes, and biosecurity, enhanced biosecurity, especially in farms and agriculture, and strengthening detection, lab capacity, surveillance, response, strengthen diagnosis at case management, and medical countermeasures like new drugs and vaccines, and recovery resilience. So based on this framework, we are also working, and it's an invisible enemy. Especially now 2 cases were reported in West Bengal, and both of them were health workers. They had treated a person with acute respiratory distress syndrome, and they're thinking he's the index case, that patient, and we don't know which patient is infected or not, so we have to take standard precautions. Okay, and some new newses like Japan began to first human vaccine trial in April, and Oxford also in the phase 3. And the other thing is, beyond Nipah virus, new bad virus found in Bangladesh patients. Its name is pteropine orthoreovirus, PRV virus. So many viruses are there in bats which have pandemic potential. And alert to health workers from April to September. You can see the graph, and you can in the next picture you can see in 2018 how these cases, most of the cases were nosocomial from hospitals. So we should take precautions in hospitals and learnings from global experience. And we had conducted a global webinar on Nipah from Johns Hopkins University. And you can see my professor, Dr. Emily, and Mahmoud Rahman from Bangladesh, and Pragya Yadav from India. And all of these three persons contributed to the strategic plan of WHO. And Dr. Anish sir was there for the discussion. But the real learning is not from Johns Hopkins. The real learning was from 2018 Kerala Nipah outbreak response. And actually my career started with these legends without any protocol, and we created the protocols from vacuum. And I really value the learnings from this 2018 Nipah management team. I think Sarita madam is here. Okay, these are the things. And bats, we are trying to implement the concept of living with bats, because if it do harm to the equilibrium between human, animals and health, it will cause zoonotic diseases. And it's the concept of One Health. And we can take precautions, and we can have a Nipah free Kerala. Thank you. Thank you so much.
Thank you, Naveen, for taking us through the virus and the transmission and the future threats that we may have to look into. And I also acknowledge the presence of Sarita ma'am, then Director of Health Services, and Madam's compassion, leadership and commitment. We all should acknowledge. Thank you, ma'am, for joining us today with this meeting. And now we move on to the next presentation. This is the topic is clinical red flags, when to suspect Nipah. It's done by Dr. Anoop Kumar. Over to Anoop Kumar.
Evening, respected panel members and dear colleagues. So, I'll be moving through the clinical features of Nipah virus, emphasizing mainly on how to clinically detect Nipah virus. So, I'll start from the first case, what we detected in 2018. So, that time, a 26-year-old man was presented with 3 days history of fever. Then he was not giving any history of travel. CT head was normal. He presented with features of encephalitis to our ICU in Baby Memorial Hospital. So any patient coming with fever, altered sensorium, the clinical diagnosis will be acute encephalitic syndrome. And we do a CT head before proceeding with any CSF examination. So he had fever, vomiting, then breathing difficulty, and was not having much cough, and he was having altered sensorium. This was the initial CT. As you can see, there is like features of brain edema. Other than that, there is no parenchymal abnormality. So the vitals were like, as you can see, his BP and heart rate were on the higher side. He was conscious, disoriented. He had he was restless, and he was moving all four limbs. And in chest, he was having crepitation. So later, his three other family members were also got admitted to our ICU with almost similar symptoms. And the common symptoms which we observed in these patients were all these patients were having adrenergic response, like they were having severe tachycardia and hypertensive response, which is very unusual in encephalitic patients. Few patients had segmental myoclonus, and that is the first time we were observing segmental myoclonus in an encephalitic patient. And one patient was having ptosis, that is a brainstem sign, which is also very unusual in normal encephalitis. And one patient was also having segmental fatigue. So these unusual clinical features in a group of patients were observed at that point of time. And the first Nipah report of clinical features published in NEJM way back was also substantiating all these abnormal features. In that you can see the segmental myoclonus is a very typical feature of Nipah. So as I've already told, tachycardia, ptosis, segmental sweating, hypertension, segmental myoclonus, dysarthria, or abnormal pupils, seizures, and cerebellar signs. These are the very clinically catching signs for a Nipah infection. And this patient was like we have taken an MRI later for that patient, but it was reported normal. But later I will explain that what findings are there in that CT. And this is the usual CBC picture in a Nipah patient. You can see, this is a CSF study at that point, initial 3 patients. All the CSF samples were normal. This is another typical finding in Nipah. In early presentation time, the CSF will be normal. This was also reported in Malaysian outbreak as well. It can happen with many other encephalitis also, but typically described with Nipah virus. So that time what made us to suspect an unusual infection was there was an index patient who died 2 weeks in medical college. The clustering of patients from the same family and the unusual clinical features which I've already discussed. So these were the points which made us to suspect about an unusual clinical syndrome. That is how we investigated that and sent the samples to Manipal Virology Institute and later confirmed it as Nipah. And this is another important finding. As you can see, these are the PCR samples which we have taken from initial 5 patients admitted in Baby Memorial Hospital at that point. You can see all patients' CSF sample were negative for Nipah PCR. But the throat swab was positive and the urine was also positive. So from that point of time onwards, nowadays we are screening the Nipah with throat swab alone. Ideally, whenever you have a suspicion, I think Dr. Anitha will be discussing that in detail. You have to do all body fluids like throat swab, urine, CSF, etc. But Nipah being a respiratory virus, it can be demonstrated in a throat swab itself. So you don't have to go for a CSF examination. So that is why nowadays we isolate all the patients coming with features of encephalitis. We do a throat swab for Nipah, then only we'll remove the precautions in those patients. This is the typical CBC picture. You can see hemo concentration. Then in the urine examination, the microscopic hematuria and microalbuminuria. So patients having these features with an encephalitis, again you have to suspect the possibility of Nipah. And the MRI, you can see there are minute these T2 hyperintensities. So here this MRI, you can see the a better picture. So any patients coming with these type of MRI pictures, that also mainly in the white matter, these micro infarcts, that is also very typical of these Nipah patients. You might have read in the newspaper this time also, 2025 outbreak was reported in West Bengal. 2 nursing staffs were reported, one a male staff and a female staff. Both were admitted in a hospital, and actually the radiologist picked this time with the MRI finding. They were having a typical MRI finding that time, and then they sent the swab, later came positive. So these typical MRI findings which we missed in 2018, should not be missed by any other clinicians hereafter, especially from our area. So this is another patient which was treated in MIMS in 2021. Here again you can see that features which I have already told. This is another patient again from our Kerala group only. Here again you can see these micro infarcts like hyperintensities in the white matter. This in 2023 again there was an outbreak reported by our team again. So here also the patient was like one index patient was there who died in ICRA hospital 2 weeks back. He was actually died with an ARDS, but later on when we took a detailed history, he had features of encephalitis, like he had dysarthria. Then a clustering occurred from the same group, and these patients were from the previous Nipah epicenter. So that is how we were able to diagnose Nipah in 2023. And this time also we had the same picture, hemo concentration, proteinuria, but microscopic hematuria was not there. And this is the boy's like MRI who survived after encephalitis, who was ventilated for 4 days. Here again you can see the features of these brainstem encephalitis. So this is one case who survived after having a brainstem encephalitis without any neurological deficit. The child is still under follow-up without any features of relapse. So in 2018, the first cases were reported because of clustering and unusual clinical features. In 2019, the patient was reported from Aster Medicity, Cochin. So that time the patient was admitted with features of cerebellitis, and multiplex PCR was sent as a part of routine examination, which came positive for Nipah. 2021, the case reported from MIMS was again picked up from the MRI findings, and later the CSF findings were also normal. That is how they suspected and diagnosed. 2023, which I have already told our experience, clustering, unusual clinical features, and the patients were from the near epicenter. So that is how we were able to establish a diagnosis in 2023. In 2024, the cases from Perindalmanna, again the patient had autonomic instability, segmental myoclonus, and typical MRI findings, but unfortunately the initial clinical team missed that MRI finding, and they were not able to clinically detect its segmental myoclonus. So with all these features, we actually made a scoring system, including the history, the clinical association, lab finding, imaging, and neuroscience. So all these things, if we can combine, we can form a scoring system. A patient with a contact with an ARDS or an encephalitis case, we can give a 3 points. Consumption of not properly cleaned fruits, then history of any dysarthria, or the combination of these things. This is also very important. A patient with encephalitis along with ARDS, this is an unusual combination. For a patient with encephalitis and myocarditis, you can have a combination of all these three also. So in those group of patients also, you should have a high index of suspicion. Any patient coming with ARDS showing any features of encephalitis, and vice versa. Any patient coming with encephalitis going for ARDS. Then a normal CSF study, hematocrit, I have already told, hemoconcentration, microalbuminuria, hematuria. And the clinical features I have told, ptosis, tubular asymmetry, cerebellar signs, adrenergic surge, segmental fatigue, and segmental myoclonus. This segmental myoclonus is very important. So we can combine all these history, association, lab features, imaging, etc. If you combine all these scores, and if the score is coming more than 15, there is a high possibility or high likelihood of having a Nipah. So the clinical features I have already told: clustering, adrenergic response, myocarditis, and the brainstem signs. Along with MRI findings, this is a main clue towards the diagnosis. And whenever you have a diagnosis or suspicion, immediate isolation is very, very important. So like that is why in 2023 and or we were able to limit the number of exposure to less than 5. Like remove the isolation only after getting a negative throat swab or any other PCR for Nipah. Then appropriate personal protection equipment should be used. History, the clustering, and the warning clinical symptoms which we should not miss. Then I've already told, always throat swab, that is important. Then don't miss the MRI finding. Encephalitis surveillance and CSF panel, that is also very important. I think Dr. Anitha will be speaking more on what is this CSF panel and how to send those samples. Thank you so much.
Anish for that description, practical experience. When you are in the periphery, you are seeing the first case. That is always all patients have fever, and we have altered mental state, ARDS, myocarditis. So the combinations of these two, we have to suspect. Obviously, if the classifications are there, I'm sure everyone in the tertiary care, because most of the time I used to hear that they are saying, oh, this patient is sort of tell whether there are people from outside there, please excuse me. ഇതൊക്കെ കാണിക്കുന്നത് ഇത് മിക്കവാറും അതാവും. This is the way of seeing cases again and again, and Anoop has put it in the right perspective. Now we move on to the most important part of early diagnosis. Because early diagnosis is always reducing the magnitude of the outbreak. So diagnosis protocol in sampling to Anitha.
So good evening all. Thanks to IMA for the opportunity given. I'll just be briefly taking all with an overview of how we go about with our diagnosis of Nipah cases, and then a brief brush on the infection control measures. I cannot have a complete session though. In 2018, actually, when the first Nipah outbreak was declared, it was a new term for most of us. From then on, it was in 2019 that we had the next case, and 2021 was the time when we actually started testing for Nipah. Okay, so we started with RT-PCR tests for Nipah. The NIV team from NIV Pune, the ICMR team, they actually handheld us, and then they taught us how to go about with the diagnostic aspects. And then we started with the real-time reverse transcriptase PCR then. Ideally speaking, these tests have to be done in a BSL-3 lab, but we didn't have one then, and now we have one under construction, not fully done. Hope it will be done soon. Now what we are doing is we are testing for Nipah in a BSL-2 laboratory with BSL-3 practices. Okay, so that's the difference, or that's the additional infection control precautions we are using when we are testing for Nipah. What tests we do generally, or what is the flow of work we do is, initially when you have a patient in the casualty or in the OP or any place, it could be an IP patient even, when you suspect Nipah, like all those signs Dr. Anoop was very well giving us an information about, what is it that you should do? You should take samples, and they have to be sent for Nipah TrueNAT test. Nipah TrueNAT is actually a modified version of the actual RT-PCR, where the time gap is reduced. So you get to have a probable positive patient can be picked up much earlier than the time it takes when you go for the actual RT-PCR. Okay, so initially we go for a Nipah TrueNAT test. We do usually with nasopharyngeal swab or throat swab, and then if Nipah TrueNAT is positive, then immediately we take it up for RT-PCR or real-time reverse transcriptase PCR, which is a more cumbersome test. It takes around 6 to 8 hours. If that also comes positive, then the sample is immediately shipped to NIV Pune for confirmation. At the same time, we inform all health officials, because if RT-PCR is positive, it is to be taken as positive unless proved otherwise. Okay, so the Nipah TrueNAT positive goes for RT-PCR, but it's not that Nipah TrueNAT negative can be taken as a negative case. Like Dr. Anoop was saying, we generally use only one sample for Nipah TrueNAT, and because it is most often expected that the nasopharyngeal or throat swab will give a positivity. That's the sample that is selected for Nipah TruNat. Okay, but there is instance, or there are instances where Nipah TruNat is negative, but when you test with RT-PCR with a whole lot of samples, you get a positive case. That actually happened in 2024 with one of the cases where the initial TruNat came as negative, but the real-time reverse transcriptase PCR with the other samples came as positive. Okay, it's not that TruNat is not sensitive enough. The reason being we are testing only with one sample for TruNat, and it does not become economical to test all the 5 samples. It will work out something like 10,000 for each patient. So that's why we restrict to one sample. Okay, so whether it's negative or positive, all TruNat samples are taken up for RT-PCR also. Okay, so what is it that we do when we get RT-PCR positive? All the health officials in the state are involved, are informed through proper channels. That is, we inform the principal, superintendent, and this goes on to inform the DME, the DHS, the health minister, and so on. And everything gets started in place even before the confirmation comes. So there is no waiting for setting up of a control room or to start off with contact tracing, which Dr. Anish will be telling you in much more. He'll be giving you a better description of. So all these things get started with initial RT-PCR positivity itself, and the confirmation usually takes about 18 hours to come from NIV Pune. Okay, so the why is one reason, one question which we are most often faced with is, why is that your reports have to be confirmed by NIV Pune before it is declared? Like Dr. Naveen was saying, this is a BSL biosafety level 4 pathogen. So once it is a 4 pathogen, whenever you are giving a positive report, the whole world is actually watching on. It's supposed to be a global watch, global alert when one case is reported. So that case has to be confirmed from the center, and it is the ICMR team from NIV Pune who is entrusted with confirming of the reports. Okay, so that's the reason why our samples go to NIV Pune for confirmation when it is the first of that particular cluster or the outbreak. Okay, so if you look at the diagnostic aspects, we have been able to pick up these cases pretty soon enough in the early phase, and that has helped in containment of infections. And the turnaround time, like it was much more earlier, like around 48 hours initially, but now the turnaround time is reduced to less than 12 hours. And that actually helps to put all these precautions in place as far as the hospital is concerned, and to have all the contact tracing in the field activities. Okay? So that's the importance of why we should be picking up cases at the earliest and going about treating and containing the infection. Okay, so then coming to the samples that you need to be sending when a Nipah case is suspected. We said nasopharyngeal or throat swab is one important one, but you also have to send blood sample, CSF sample. Like Dr. Anoop was saying, you don't usually get CSF positivity, but if there is encephalitis, anyway CSF sample is taken, so CSF is also tested, and then the urine sample. Okay, so these 4 samples have to be tested in every case before you actually rule out a case of Nipah. Okay. Now, where do you collect the sample from? Suppose you have a patient who is suspected. You cannot collect from an OP or from an IP ward. You have to see that the patient is taken to an isolated facility, and the person who is collecting the sample should be wearing appropriate personal protective equipment. That's very important, because collection of a sample is a very hazardous procedure, and if the patient is positive, the person who is collecting can be infected. Okay, so for full PPE is essential, and the patient should be in a isolated facility before we collect samples for Nipah testing. And how do you pack it up? I'm sure everybody here will be familiar with the triple package. You take it in the container. Now the issues that we generally face is, one is leaking of the samples. Suppose the screw cap is not fastened properly. Suppose you don't seal the caps with a parafilm. And another thing we face is the smudging of the whatever is labeled on it. That is another issue that we face. It is difficult to read through. The importance of all this is because when you see how our technicians generally test these samples, I said it is BSL 2 lab, we don't have a 3 lab with negative pressure. They usually use what is called as PAPR, that is the powered air purifying respirator. So you can see that they have to wear the coverall with the PAPR, and that is a bit cumbersome. And to see that at the end of all that effort, you are unable to test the sample because it has leaked or because it is smudged and the labels are not clear enough, that is a bit disheartening. Okay, so that's the reason why samples have to be properly labeled, properly sealed before it is sent in a triple package. Okay. We also do follow-up of Nipah cases. When we have a positive Nipah case, it is the patient is followed up every 4th day. The samples, all these samples are tested again, and unless we get 2 consecutive tested negative, the patient cannot be discharged. If fit for discharge, that patient cannot be discharged unless they have 2 consecutive Nipah samples negative in all the samples. A genotype, Dr. Naveen has already said, we have the Indian genotype which forms a subcluster in the Bangladesh genotype phase. And what we have seen in the bats and what we have seen in the humans is more than 99% similar, and that tells you how we actually must be getting the disease with spillovers from the bats. And regarding the biosafety measures, it is not that we follow biosafety measures and use coveralls in an isolated facility where the Nipah patient is admitted. These measures should start from the casualty, from the OP, wherever it is possible or it is likely that you will come across a patient with Nipah. You should be following standard precautions. And we have seen that in the recent years, the chances of transmission has been much, much lower, and that we should be thankful to COVID. COVID has taught us all how to be using all these personal protective equipment. So simple mask, gloves and a gown if there is spillage, especially when you're doing aerosol generating procedures, it is very important that we follow all precautions. Okay? So that's before you have a Nipah positive case in the isolation. How you deal with death is also important. The dead bodies have to be given a double wrap, and then cremation is a must. It belongs to the category 3 of the death classification. So how you deal with the patients as you see them in the OP, to the testing in the laboratory, treatment in the isolation facility, and even death if it occurs is important, because most of these cases are highly infective by the time they reach the hospital, and we have seen that ARDS cases especially are more likely to transmit because their secretions are likely to be teeming with the virus when they reach the hospital. So no gaps should be left in infection control so that none of the healthcare workers are infected, because we know how fatal this infection can be. And whenever we have such outbreaks, we also have a series of trainings going on for the residents, for the doctors, for the laboratory technicians, and all of them who have to be following enhanced step up of the infection control measures that they are routinely following. So when it comes to Nipah, that's where you actually get to see what is the strength of a teamwork. Now we have Sarita madam here, and we have people from the health service also who have worked, and you know how this whole team works when there is an outbreak, and that is really something that you cherish. At the end of the outbreak, when it is declared that it is Nipah free after 48 days of no more Nipahs, everybody feels that elatedness, and that is actually the strength of the teamwork that is put in, not only in the institute between the different departments, it is between the in the state with the health service, the DME, and as well as you have teams from NIV, NIE and NCDC, all of them coming in, and the main reason for being in the team is for containment of Nipah. So I hope we have been effective in detecting all these cases since 2021, and we hope we don't have many more in the near future. Thank you all.
Thank you, Anitha. The point is very clear. If you suspect a case, we have to take sample, full PPE, And as far as possible, the suspected patient should be in isolation. And negative, we can say that the patient is negative. So the undue delay happens in declaring the results as well. And if CSF is done, we have to send the CSF as well. And all the important points she has stressed, and we will take up questions as we go to the open forum. So now I invite Dr. Shamir. He will be discussing on clinical guidelines and emerging therapeutics.
Thank you, IMA, for this opportunity. So we are moving towards the last part of the session, just before Anish sir's session. So it's a treatment of Nipah virus infection. So as all of you know, we have very limited evidences, and so I may not be able to talk on an evidence-based medicine when we come to the management of Nipah, because we have a very few experience and we have only a very limited number of cases all over the world, maybe limited to less than 1,000. So the evidences are seldom. It's mainly a personal experience-based management we are doing now. So this is our last patient. We had a 38-year-old female from Palakkad presented with fever, cough, vomiting, followed by altered sensorium and dyspnea. And she developed multiple episodes of seizure. She was mechanically ventilated in a private hospital near Perithalmanna, and Nipah PCR was positive from there. And she was shifted to our Calicut Medical College. And on admission in our college, she had a GCS of only 3, and she had no spontaneous respiration. Pupils were sluggishly reacting. That was the only sign of life actually. And but the vitals were stable. BP and heart rate were stable. So this was the condition we received the patient, and this is the patient. He is still there in our college. So we have a very beautiful guideline which is provided by our Kerala government. I think that should be the number one and the most efficient guideline all over the world, which is available for managing Nipah. And Chandni madam is also a member of this team who is providing this guideline. So we were following this guideline, and when you search the literature, you can see a lot of drugs evolving over a period of time. And when you go to all these papers, you can see almost all names mentioned here. It may not be clear for you. You can see Kozhikode sir name, Chandni madam, Anoop Kumar is there, and Anoop Warrior is there. Almost all main stalwarts in infectious disease, general medicine, you can see in this paper as an evolution of management of Nipah. And the first drug which was used especially in Malaysia was ribavirin. And the same thing was, we also used the same drug in the initial epidemic of 2018. That was the ribavirin. That was the only antiviral that was, we had some hope in treating Nipah. And in the Malaysian experience, they reported a reduction of mortality around 36%. But on further studies, especially in animals, most of the studies regarding Nipah is animal studies, because it's not possible to conduct these studies in human. That's a basic issue. So the animal studies, latest studies failed to show any improvement, and we used the same, and we gave in 10 patients. And 2 survived. We don't know whether it was due to ribavirin or not, especially because most of the patients who received ribavirin who expired were received in the last stage of their illness, because they came very sick. Most of the patients went into ventilator within few hours time. And even we could give only one dose of ribavirin or so. So we have no clear data whether it gave any benefit or not. Then came the favipiravir. Actually, in 2018, when we were managing the Nipah, we were desperately asking for this drug. I still remember we were writing letters, even we wrote letters to Japan and all, to import favipiravir, because we heard that that drug is available there. They are using it against influenza. And we couldn't get such a drug at that time. Later it came during our COVID period. And it is said to have some effect in Ebola. It is used against influenza. And it's a viral RNA dependent RNA polymerase inhibitor. And it has some effect in favipiravir. Again, all the studies are animal studies. No much studies in human. Then came the most important drug, the drug which we used maximum as an antiviral. I think after acyclovir and oseltamivir, maybe this is the antiviral which we have maximum experience, because we had the COVID and we used in plenty, and we are very happy in using this remdesivir, and we didn't have much side effect also. So this remdesivir came into the picture of management of Nipah, and we were very happy to use remdesivir. And again, the studies are basically in animal based. These are all African green monkeys and all, and they gave a very good report when the studies were done in animals. And the study says that when remdesivir was given at a period within 3 days of infection, there was a very good effect in preventing a severe disease. There was almost a 67% reduction. And when they studied this animal, they could still find the evidence of infection. Even there were findings in the brain, but still the severity of the disease was less. So that was a very important paper regarding the management of Nipah virus infection. That is the role of remdesivir in Nipah virus. So the treatment option summarizing, we have the ribavirin, the first drug that is used, with no much evidence. Favipiravir, which has some evidence in animals, and the last one, remdesivir, which has the maximum evidence. That is, again, I am repeating, it's in the animal models. So considering all these things, in the last few patients, we were using remdesivir, and came the this molecule which we have the maximum hope, and it's a monoclonal antibody against Nipah virus, that is 102 M102.4. And one of the most important persons regarding this monoclonal antibody importing to Kerala is here, that is Chandni madam. And with madam and our health minister, all these policy makers, they did a very crucial role in bringing this monoclonal antibody from Australia to India. In 2018, again, we were desperately waiting for this monoclonal antibody. Finally, it reached Kerala, but no patient came after the antibody reached, so we couldn't give that. The second time, I think in Ernakulam, again, madam went there to administer this. That time, the patient almost improved and he recovered. And finally, the last 3 patients, one patient who, the healthcare worker, who developed a relapse encephalitis, he was given, but it was not the ideal indication where a monoclonal antibody is to be given, but still as a compassionate measure, they tried that. And the last 2 patients, the patient which I mentioned here, and another patient from Perindalmanna Malappuram part, both these patients received monoclonal antibody in the correct time, almost in the correct time, and both of them are surviving till date. So it's a hope we have now. So these are the path through which the monoclonal antibody developed, and it's again it's against the G glycoprotein by which this Nipah virus binds to the heparin receptor. So most of these trials, phase 1, phase 2 trials, phase 1 trial, there was no much adverse effect. That's the best advantage. Only the maximum side effect was headache. No much adverse effects were found, and that is the hope of the day now when we talk about the management of Nipah virus infection. And about the role of immunomodulators like steroids or other agents, as we know after the COVID infection, we use a lot of steroids and other immunological agents in treating a viral infections. Similarly, in Nipah also, it is considered to have a dysregulated immune recruitment, and many of the findings are like an acute vasculitis. So there can be some roles for immunomodulators like steroids, but the use is restricted as of now. But there are some conditions like if the GCS is very bad, if there are features of raised ICT, and there is a rapid deterioration of the neurological status, and if there is a typical cytokine storm or HLH like presentation, all these indications are, all these conditions are indications for immunomodulators. But our Kerala government guideline specifically gives such a sentence: the early use of immunomodulators in Nipah encephalitis is not supported by robust scientific evidence. The decision must be made based on opinion of institutional medical board on a case-to-case basis. So, coming back to my patient, this was the prescription. So, this was the orders from our case sheet. So, it's to emphasize that it's not the antiviral, it's not the monoclonal antibody alone. It's a supportive management, it's a critical care. All these matters a lot. So, the patient should receive the maximum supportive care, maximum critical care, maximum ventilatory support, because all these patients are going to have multi-system involvement, ARDS, myocarditis, hemodynamic instability. So they need the utmost care one can provide, because why I am emphasizing on this point, because Dr. Anoop, me, myself, all of us, when we were managing these cases in 2018, everyone was afraid to enter the Nipah isolation room to see the patient. When we call for a help from another department, the first question they will be asking will be, should we take such a risk? Are we taking that risk for such a patient? Do you have any hope in this patient? Because already it's gone. It's a Nipah, it's an encephalitis, it's already in ventilator. So anyway, that is 0% chance, and we are taking a risk by entering this. So why should we? So that question was actually, it was a very disappointing questions which we always faced from all other supporting departments. So nowadays the things are changing. So they need all these support. They need anti-epileptics. This patient also received mannitol for decreasing raised ICT. And all these things together can make a difference. That is the message I want to give you today. And regarding the post-exposure prophylaxis, Kerala government also gives a clear-cut guideline for this. That's again the drug recommended is remdesivir. In a high-risk contact, remdesivir, almost the same dose for 12 days we have given in the last few cases. Favipiravir is also the second choice. And this was the guideline given from the recent 2026 Bengal. They are using both together, remdesivir and ribavirin. That is the guideline given by them. So, as Dr. Naveen was mentioning, some hopes again, some vaccines are in the pipeline. They are trying to conduct the studies, and it's ongoing. Phase 1, many have completed, and phase 2 trial, 1 vaccine has already completed. So maybe in a near future, we may get some vaccines for our protection also. So this is the patient which I showed earlier. It's a most recent, at least her child could sit on the lap of the patient. A patient who came in such a bad state, you can imagine with any etiology in that condition, it's extremely difficult for such a survival. But with Nipah, which already has a mortality of more than 70%, coming in a GCS of 3 with almost no signs of life at all, improving to this state means we have a hope. Maybe the remdesivir, the monoclonal antibody, and above all this, the confidence of healthcare workers, that is the difference. That is the point that brings a difference. Because if we are not confident, we are not going to manage the patient properly. This patient received almost 24 hours round the clock a doctor, round the clock a nurse, all the healthcare workers, specifically for this patient. That these people are managing no other, and madam, as the chief nodal officer, the whole system, the lab, every day we were talking, we were calling, and that was a management given to this patient. And finally, it's actually a thrilling and proud moment for all of us. It's a success of the Kerala government guideline and all the team, including, and I should mention Jithin also. Everyone was mentioning the team. He was one of the, I think, is one of the rarest doctors all over the world who did a autopsy in the Nipah positive patient. I think the first patient autopsy was done by, and incidentally he is conducting this webinar. So thank you all for this opportunity once again.
Thank you, Chamir. He has emphasized the need for intense supportive care. And from 2018 2026, we have moved a lot, and maybe COVID has also taught us a lot of lessons in dealing these patients in ICU, because intubating, managing everything will be very, very difficult in that situation. And we have become more confident because we have monoclonal antibody in 3 patients, and all of them are surviving, but with a lot of problems. Maybe we hope over the years they will be able to come up from this morbidity as well. So now we move on to the most important part of the session, public health resilience beyond the hospital walls. So we are all eager to hear. Over to Dr. Anish.
Respected Chair Chandni Madam, Sarita Madam, dear friends, dear IMA leaders and friends. Whatever I wanted to talk is already finished. So I just tell a few things about building resilience. So basically, building resilience, if I am speaking in a public forum, I may be speaking more about the conservative type of. For example, you have to, as Dr. Naveen has already mentioned, we have to live with bats. That is the most important thing that we have to mention, or we have to think while you are just pondering on the building resilience. Here I may be modifying my lecture based on the group whom I am speaking, that is doctors. This is our history of events that Dr. Naveen has already mentioned, that we had 10 spillovers till now. And out of this 6 happened in the last 2 years. That means Nipah spillovers are increasing its number. Maybe because of our increased surveillance, maybe because the disease is maybe spread more in the southern part of Calicut, that is Malappuram and Palakkad. So I am not going to detail. Nipah, this is also mentioned by Dr. Naveen. Nipah is a concern for us because of many reasons. One is the universality of the reservoir host. Every evening while you are walking, you can see that the reservoir host is on your maybe in the skies. And there is multiple host tropism. Even if we do not have an evidence that an intermediate host is there for the Nipah virus that is transmitted in Kerala, but experimentally, when you are treating the animals with this virus, each and every animal is infected. The cats could be infected, dogs could be infected, even birds could be infected. So any animals could be act as an intermediate host. We do not know what are the transmission patterns in Kerala. Sometimes the cats or dogs may be acting as the intermediate host, and we are not recognizing that. That may be a possibility. And another thing is the super spreading, the chances of super spreading. Super spreadings are considered as the engines of a pandemic. Because if you know that, okay, this disease is going to affect many number of people, we can take necessary precautions. But in Nipah, 90% of times it will end up in a single case. But in 10% of times, wherever that is going to occur, we do not know, there will be large number of cases, and often it will be in hospitals. So hospital-based super spreading is a pathognomonic feature of Nipah, because Nipah has got a transmission towards the later symptomatic phase of the disease. Suppose the phase of Nipah infection is for 5 days. First 3 days there may not be any transmission, but on the last 2 days while the patient is in hospital, severely ill and maybe having all the signs and symptoms, maybe transmitting the disease. So the Nipah transmission will happen in hospitals. It won't happen in a Kalyana Mandapam or something like that. Because a patient who is able to go to a Kalyana Mandapam in that kind of a health status may not transmit the disease. A sick person is going to transmit the disease, and that means the hospitals, the doctors, nurses, and other patients and all other people are going to be affected. It's the same thing that you just look at wherever the Nipah transmission happened, especially in the Bangladeshi strain, you can see that always in the hospital. In Bengal, it has happened in the hospital. In Kerala, we had 2 episodes. One is in Calicut and second one is again. Both are in the Calicut. So we used to tell that which district has got maximum number of Nipah spillovers. Which district in Kerala has got maximum number of Nipah spillovers? It is not Calicut, it is Malappuram. Now we have got 4 spillovers in Malappuram, only 3 spillovers in Calicut. But which district has got maximum Nipah patients? That is in Calicut, because both the outbreak happened in Calicut. So there are a lot of concerns about Nipah, especially because it is for doctors it is a concern because it is an occupational disease for us. So this is how much big Nipah outbreak could be. That is the question. Usually whenever you are just discussing, when there is a Nipah outbreak, people will tell that it will be a very small outbreak. Because there is no Nipah outbreak, maybe more than 50. There is in Malaysia, there was an outbreak for 200 or something, but that was a propagator type of outbreak. It is not that kind of an outbreak happened in Kerala. From a hospital, there is an outbreak. Maybe 10 or 20 people will be involved. But we cannot depend or we cannot confident on Nipah because the viral nature can change at any point of time. So the Nipah can, because of the super spreading nature, the number could be very large. For example, in Siliguri, that is in 2001 outbreak, the first outbreak reported in India, almost 70 people were affected and most of them were doctors and nurses. So that is the importance of the Nipah, and there is the picture you have already mentioned that in Calicut in 2018, you can see that from single patient in a single area, how many people are getting infected. And on the right hand side, you are just seeing maybe a theoretical pattern of maybe a super spreading. That means a single person is going to create a large outbreaks. So next question, it's a very important question. Can we eradicate Nipah encephalitis? We cannot eradicate Nipah encephalitis because there is a true reservoir present. Any disease where there is true reservoirs, you are not able to eradicate it because it will be there in the environment. Because it is not killing the bats. Bats are very happy with the Nipah virus. And at the outbreak times, especially during April to September, whenever NIV people are coming and collecting bats, in 50 to 100 bats, they will get one maybe RNA positivity in Pteropus medius. The other Rosetus and all are not that much important because we are not getting only antibodies. And in PRNT test, that is not neutralizing antibody. So that may not be very important. But Pteropus bats, at any point of time, 1 to 2% bats harbor the virus. It is not the antibody, it is a virus. So that is a large, that is even in Bangladesh, we are getting that kind of a pattern. Even in West Bengal, following this outbreak, the same pattern. That means 1% of your bats contains virus. So we are not able to eradicate the virus at all. That means this virus is going to be with you. The only thing is you have to take necessary precaution to prevent the spillovers and outbreaks. So there is a lot of possibilities for Nipah transmission because direct transmission could be there, maybe from its excreta, from the fruits that we know. Sometimes some people will eat bat, handling bat, or sometimes they will disturb bat. And sometimes indirectly through maybe liquids like date palm sap, any intermediate host. But if you look at the Nipah cases that happened in Kerala, 60% of Nipah patients were coming from the hospital-based super spreading. They are not getting Nipah from bats. Rather, they are getting Nipah from other Nipah patients. So transmission, or preventing person-to-person transmission is very important in preventing Nipah infection. So can we stop Nipah spillovers? Yes, we can stop Nipah spillovers. Let it be in the environment, but we can stop the transmission to human beings by taking care of all these things. One is protect the environment and the bat roost. So whenever the recent Nipah outbreak, when we are just going to field, we are seeing that Nipah outbreaks are happening in areas where the bat roosts are disturbed. In the Palakkad, that is the recent Nipah outbreak, that roost, that colony is there for 10 years. There is no Nipah outbreak. Sometimes people will ask, how could you know that there is no Nipah outbreak for last 10 years? There is no unnatural deaths in last 10 years in that area. But following the Malappuram episode of Nipah spillover, people become panic and they were trying to disturb the bat. What is going to happen if you are just disturbing the bat? Sometimes you will cut down the roost. What will happen if you cut down the roost? Bats will come again to the same place. They have invested a lot in the place. We do not know how they are choosing the place, but they have invested a lot in the place. They do come. As far as possible, they will identify a tree very near to that. Sometimes the first tree may be maybe 50 meters away from her house, and the second tree may be very close. In Malappuram, in Palakkad, that has happened. It was actually the tree is the colony. The house has become inside the colony because they disturbed the roost. So we do not know how the bats are going to act. Another thing is, we know that now 1 to 2% in outbreak season, Nipah the bats are infected by Nipah. But what prevents us from getting Nipah infection? Nipah still it is a rare disease. If 1% of bats are harboring the virus, but then why it is a rare disease? The only reason is bats are active in the night and you are active in the day. While you are active, bats are just resting. Just let them rest. That is very important for you. What you are doing, you just put crackers. Maybe you have got an air gun and you may shoot and make bat disturbed. That means there is a more likelihood of human to human interactions. So let bats be there. That is a very important thing in building the resilience. And the preventing spillover for you, it's very important that the madam has discussed about the importance of PPEs and all, but a mask is very, very important. In hospital, you do not know who are going to come to you, maybe for treatment. That may be a Nipah patient. A mask is going to save your life. No health workers wearing mask at the time of treating or maybe caring a Nipah patient got the disease in history, of Kerala at least. We were just looking into the CCTV footages and we see that many nurses, even the nurses who are affected by the disease, were not having mask while dealing with a patient with AES and ARDS. So that is a very important thing that you have to keep a mask. And soap and water will also good. If sanitizer for a doctor's practice is also important. So these kinds of simple measures are very, very important. And another question is, can we identify the spillovers? That means a first case of an outbreak and prevent deaths and stop transmission. Yes. AES and ARDS surveillance is nowadays in Kerala. We are identifying even the first case. Now we know that in 2024 and 2025, 6 cases were there. There is no transmission. Eventually, we are actually identifying the first case. So that kind of things are happening. And many things are helping. For example, one patient who is affected by Nipah in Malappuram district and treated by a neurologist called Dr. Anoop. And Dr. Anoop picked the segmental myoclonus and suggested that for a Nipah testing. So that is very important thing. A forensic surgeon recently had got a case. Maybe I am speaking about the 2025 case. One case from Malappuram. The forensic surgeon, while reviewing the case report, just suspected the clinical features are very similar to that of a Nipah. Let us test it. So the forensic surgeon is detecting Nipah case. So what happened in Tiruvali, that is in Malappuram, an ASHA worker, the patient was there in a private hospital and had bleeding manifestation, and at that point of time the dengue outbreak was happening, and the doctor was thinking that it is dengue, and before getting tested the patient died, and the patient was cremated at the home. But the ASHA worker who visited the home detected that it's a case of AES and reported to DMO, and DMO just just contacted the private hospital, get the leftover samples and tested Nipah, and it was found positive. So these kinds of activities are happening there. Everybody knowing about the signs and symptoms of Nipah is actually an asset, so that we can identify this disease. And if you are able to identify the first case, what does that mean? You are just preventing further transmissions. Even we are saving that first patient itself. It was first case of a Nipah patient. Saving the first case, the index for the primary case, is actually a Herculean task. Because while you are detecting Nipah case, the patient would be clinically very unstable. But still we are able to save them, maybe using monoclonal antibodies, critical care, remdesivir, and all other stuff. All these things were discussed. Can we protect ourselves from not getting infected from a hospital-based super spreading? Nobody wearing a mask was affected, even at the time of super spreading. So if you are in a hospital, always put a mask. And let people do not come to hospital unnecessarily. Because if there is a necessity, so a patient, definitely they have to come. Otherwise, hospitals are not social spaces. Don't just tell your patients and bystanders, do not come to a hospital unnecessarily. And there are a lot of structural changes can also be happened in hospital, because if there is a lot of aeration, maybe in an ICU there is negative pressure ventilation, definitely these kinds of things are also going to save lives. So we have a vaccine that already we have discussed, and actually 2 vaccines are in the pipeline. In papers you are seeing a Japanese vaccine, but it's actually entering the phase 1 now. But we have almost crossed the phase 2 trial for the other one, the Oxford vaccine, that is using the chimpanzee adenovirus vector vaccine. That is the same thing that Covishield is. Just like a Covishield, in the Covishield, instead of COVID-19, they were put Nipah, that is all. And the same company, that is Serum Institute of India, is going to manufacture it. And if that vaccine may be available maybe in a few years. So that is a scope that we have got. And do we have treatment for Nipah? Yes, I believe that the treatment works, because in Nipah we cannot do a clinical trial, just like a randomized control trial for this kind of a disease with this kind of mortality. The only thing is our experience. So our experience, sequential experience matters, and it is, even in Bengal, they are using our experience with remdesivir, and I think these drugs and monoclonal antibodies. And even sometimes we may get a monoclonal antibody based on our virus, because as we are saving more lives, we are getting an advantage. That these patients, we can just harvest the immunological cells from this patient, and we can build or we can prepare our own monoclonal antibody. That kind of an exercise is also going. This particular monoclonal antibody that we are using now is against Hendra. It is not against Nipah. But we may get our own monoclonal antibody very specific to the virus that is going to transmit or that is transmitting our locality. And if you are able to get that kind of a monoclonal antibody, the cost will come down. Sometimes we can use this as a preventive strategy. If there is high risk contact is there, we can, even you can, just like in rabies we are giving the monoclonal antibody, sometimes in future we can give monoclonal antibody in Nipah also. So much promising things are happening. This is what you are seeing in the left hand side is the Nipah calendar. That is a government order that what we are supposed to do in the field. And what the right hand side is a recent function that we conducted to build maybe community resilience against Nipah. So thank you. Thank you very much.
Thank you, Anish. And I think we will have 15 minutes. Is it okay?
നമസ്കാരം. എന്താ പറയേണ്ടതെന്ന് അറിയില്ല. കാരണം 2018 മെയ് മാസത്തിലെ ആ ദിവസങ്ങളെക്കുറിച്ച് ആലോചിക്കുമ്പോൾ ഇപ്പോഴും ഉള്ളിലൊരു വിങ്ങലാണ്. അതുകൊണ്ട് തന്നെ എനിക്കധികം പറയാൻ കഴിയില്ല. പക്ഷേ ഒരു കാര്യം തീർച്ചയായിട്ടും പറയാൻ പറ്റും. ഒന്നാമത് പറയാനുള്ളത്, ഈ IMA ഹാളിൻ്റെ മുറ്റത്ത് വെച്ചിട്ടാണ് കേരളത്തിലെ മാധ്യമങ്ങൾ വഴി, കോഴിക്കോട്ടെ മാധ്യമങ്ങൾ വഴി കേരളത്തിലെ ജനങ്ങളോട് അല്ലെങ്കിൽ ലോകത്തെ ജനങ്ങളോട് ചങ്ങരോത്ത് പഞ്ചായത്തിലെ ബേബി മെമ്മോറിയൽ എന്ന ട്രീറ്റ്മെൻറ്റ് ഉണ്ടായിരുന്ന രോഗികൾക്ക് കിട്ടിയിട്ടുള്ള നിപ്പയാണെന്ന് പറയാനുള്ള ദൗർഭാഗ്യം എനിക്കുണ്ടായിട്ടുള്ളത്. അത് അന്നത്തെ ആരോഗ്യവകുപ്പ് മന്ത്രിയും, രണ്ടുപേരെ പേര് ഇവിടെ പറയാനുണ്ട്, നമ്മുടെ പ്രിയപ്പെട്ട ശൈലജ ടീച്ചറും അതുപോലെ തന്നെ അന്നത്തെ സെക്രട്ടറി രാജീവ് സദാനന്ദൻ സാർ, അവരെന്നെ ഏൽപ്പിച്ച ദൗത്യമായിരുന്നു. ആ ഒരു നിമിഷം ഇപ്പോഴും ഇവിടെ നിൽക്കും. എന്ന് ഇവിടെ വരുമ്പോഴും എനിക്ക് ആ ദിവസം ഓർമ്മ വരും. പിന്നെ അത് കഴിഞ്ഞിട്ട് എനിക്ക് തോന്നുന്നു ശൂന്യതയിൽ നിന്ന് കെട്ടിപ്പൊക്കിയിട്ടുള്ള ഒരു സംഭവമാണ്. ഷമീർ ശരിക്കും പറഞ്ഞ മാതിരി തന്നെ അന്ന് നമുക്ക് ഇത് വൈറസ് എന്താണെന്നോ, വൈറസിനെ എങ്ങനെ സ്ക്രീൻ ചെയ്യാമെന്നോ, പേഷ്യൻറ്റിനെ എങ്ങനെ ട്രീറ്റ് ചെയ്യണമെന്നോ, എങ്ങനെ ഐസൊലേറ്റ് ചെയ്യണമെന്നോ, എങ്ങനെ കോണ്ടാക്ട് ട്രേസ് ചെയ്യണമെന്നോ എല്ലാം കഴിഞ്ഞ് ഇനി മരണത്തിന് നമ്മളെങ്ങനെ ഡെഡ് ബോഡി ഹാൻഡിൽ ചെയ്യണമെന്നോ അറിയാത്ത ഒരു സിറ്റുവേഷനായിരുന്നു. പക്ഷേ ഇവിടെ ഇരിക്കുന്ന എല്ലാവരും ചേർന്നുകൊണ്ട് ഉണ്ടാക്കിയെടുത്തിട്ടുള്ള പ്രോട്ടോക്കോളാണ് ഷമീർ പറഞ്ഞ മാതിരി ലോകത്തിൻ്റെ മുന്നിൽ കേരളത്തിന് കാണിച്ചു കൊടുക്കാൻ പറ്റിയിട്ടുള്ളത്. അതിന് വരെ എല്ലാവരെയും നമുക്ക് ഈ സമയത്ത് ഒന്നുകൂടി അഭിനന്ദിക്കേണ്ടിയിരിക്കുന്നു. നമ്മൾ കണ്ടിട്ടുണ്ടായിരുന്നത് ശരിക്കും ഈ ഒരു സിറ്റുവേഷൻ വന്ന സമയത്ത് ശരിക്കും മരണത്തിന് നമ്മൾ അഭിമുഖീകരിക്കുന്ന മാതിരിയുള്ള ആ എല്ലാ സ്റ്റേജിൽ കൂടിയും കടന്നുപോയി. ഷോക്ക്, ഡിനയൽ, ഗ്രീഫ് എല്ലാത്തിലും കൂടി പോയിട്ട് ഒടുവിൽ ഒരു ആക്സെപ്റ്റൻസ്. അതും ഡോക്ടർ ഷമീർ കൃത്യമായിട്ട് പറഞ്ഞു അന്ന് മറ്റേ ഡിപ്പാർട്ട്മെൻറ്റിലുള്ളവരുടെ ഫീലിങ്സ് എല്ലാം. അപ്പോൾ അവസാനം ഒരു ആക്സെപ്റ്റൻസ് ആയിരുന്നു. അത് കോഴിക്കോടത്തെ ജനങ്ങൾ, കോഴിക്കോടുള്ള ആരോഗ്യ പ്രവർത്തകർ, മാധ്യമ പ്രവർത്തകർ എല്ലാവരും ചേർന്നുകൊണ്ട് ഇതിനെ സ്വീകരിച്ചുകൊണ്ട് ഇതിനെതിരെ ഒറ്റക്കെട്ടായിട്ട് നിൽക്കുന്ന ഒരവസ്ഥയാണ് നമ്മൾ കണ്ടിട്ടുള്ളത്. അങ്ങനെ ജൂലൈ 1-നാണ് നമ്മൾ അന്ന് ആദ്യത്തെ നിപ്പ ഫ്രീ ആയിട്ട് നമ്മൾ ഇവിടുന്ന് പ്രഖ്യാപിച്ചിട്ടുണ്ടായിരുന്നത്. പിന്നെ നവീനെ കുറിച്ച് എനിക്ക് പറയാതിരിക്കാൻ പറ്റില്ല. ആ 2018 നിപ്പ സമയത്ത് എനിക്ക് തോന്നുന്നത് ഞാൻ കണ്ടെടുത്തൊരു മുത്തായിട്ട് ഞാൻ പറയുകയാണ്. അന്ന് ഇദ്ദേഹം കൊണ്ടോട്ടി CHC-യിൽ അസിസ്റ്റൻറ്റ് സർജനായിരുന്നു. അപ്പോൾ എന്നോടൊരാൾ പറഞ്ഞു, ഇങ്ങനെ ഒരാൾ അവിടെ ഇരിക്കേണ്ട ഒരു പീഡിയാട്രീഷ്യൻ, അദ്ദേഹത്തെ ഇപ്പം ഈ കൺട്രോൾ റൂമിലേക്ക് വലിച്ചു കഴിഞ്ഞാൽ നമുക്ക് കുറേ കാര്യങ്ങൾ ചെയ്യാൻ പറ്റും. അങ്ങനെ വന്ന് പിന്നെ ആൾ ഫുൾ ബ്രൈറ്റായിട്ട് ഇവിടെ ഇരിക്കുകയാണ് ഇപ്പം. അതിൽ എനിക്ക് അഭിമാനമുണ്ട്, അഭിനന്ദനങ്ങൾ ഒന്നുകൂടി പറയാതിരിക്കാൻ പറ്റില്ല. നവീൻ്റെ എല്ലാ ചലനങ്ങളും ഞാൻ എപ്പോഴും ശ്രദ്ധിക്കാറുണ്ട്. കാരണം അന്ന് മുതലേ നവീൻ്റെ ഉള്ളിലുള്ള സ്പാർക്ക് എനിക്ക് അറിയായിരുന്നു. എൻ്റെ DPM ആയിരുന്നു. അത് കഴിഞ്ഞിട്ട് DHS എൻ്റെ കൂടെ ഒരുപാട് സപ്പോർട്ടീവായിട്ട് വർക്ക് ചെയ്ത ഒരാളാണ്. അപ്പം എല്ലാവർക്കും ഒന്നും കൂടി അഭിനന്ദനങ്ങൾ പറയുകയാണ് ഈ ഒരു ഇത് ചെയ്തതിനും. പിന്നെ ആദ്യത്തെ പോസ്റ്റ്മോർട്ടം ഞാൻ ഇനിയും മറക്കില്ല. കാരണം ഞാൻ പ്രസന്നനെ വിളിച്ച് പറഞ്ഞ ആ വേവലാതി എൻ്റെ ഉള്ളിൽ കിടന്ന് പൊക്കുകയാണ് ഇപ്പോഴും. അതൊന്നും കൂടുതലായിട്ട് പറയാൻ നമ്മൾ ആഗ്രഹിക്കുന്നില്ല. ഇത്രയൊക്കെ ഉള്ളൂ. എന്തായാലും ഇത് ഒരു കാര്യം കൂടി പറയാം. നമ്മളെല്ലാവരും ഇത് കഴിഞ്ഞ് ഏകദേശം കൺട്രോളായി വന്ന സമയത്ത്, നവീൻ ഓർക്കുന്നുണ്ടോയെന്ന് അറിയില്ല, കൺട്രോൾ റൂമിലിരുന്ന് ഞങ്ങളൊരു സിനിമ കണ്ടിരുന്നു. 2011 റിലീസായിട്ടുള്ള കണ്ടേജിയൻ. ആ സിനിമ എല്ലാവരും കൂടി ഇരുന്ന് കാണുമ്പോൾ അതൊരു ഡെഡ്ലി വൈറസിനെ കുറിച്ചാണ്. പക്ഷെ പിന്നീട് നമ്മളെല്ലാവരും തന്നെ ഒരു സിനിമയിലെ പാത്രങ്ങളായിട്ടും മാറിയിട്ടുള്ളൊരു പരിണാമം കൂടി വൈറസിൽ നമുക്കറിയാം. ഇരിക്കുന്ന എല്ലാവരും അതിലെ മെമ്പേഴ്സ് കഥാപാത്രങ്ങളായിട്ട് മാറി. അതൊന്നും നമ്മളൊരിക്കലും പ്രതീക്ഷിച്ചിട്ടില്ല, പ്രതീക്ഷിക്കാതെ നടന്നിട്ടുള്ള ചില സംഭവങ്ങളാണ്. അപ്പം അതിനുശേഷവും ഇപ്പോഴും തുടർന്നുകൊണ്ടിരിക്കുന്ന പ്രവർത്തനങ്ങളും, അനീഷ് കോഴിക്കോട് ഇരുന്നത് വർക്ക് ചെയ്യുന്നുണ്ടെന്ന് എനിക്കറിയാം, എല്ലാം ഞാൻ ഫോളോ ചെയ്യുന്നുണ്ട്. വളരെ സന്തോഷം. എനിക്ക് ഒരു കാര്യം കൂടി എനിക്കിതുകൊണ്ട് ഉണ്ടായിട്ടുണ്ട്. കാരണം എനിക്ക് അറ്റ്ലാന്റയിൽ CDC എന്നൊരു ലെറ്റർ വരികയാണ് ഒരു ദിവസം, കേരളത്തിലെ നിപ്പ കൺട്രോളിനെ കുറിച്ച് അവിടെ വന്ന് സംസാരിക്കണമെന്ന്. അങ്ങനെ അമേരിക്കയിൽ പോയിട്ട് ഞാനിത് പറഞ്ഞിട്ടുണ്ട്. അത് ഈ സമയത്ത് ഞാൻ ഓർക്കുകയാണ് അഭിമാനത്തോട് കൂടിയിട്ട്. എല്ലാവരും കൂടി ചെയ്തൊരു പ്രവർത്തനം ഞാൻ അവിടെ പോയി പറയാൻ എനിക്ക് സാധിച്ചു എന്നുള്ളതിലും ഒരുപാട് സന്തോഷമുണ്ട്. നന്ദി.
Thank you, Sarita madam. And I think I'll just digital library. Madam was inaugurating what we are expected to see there.
Yeah, as part of One Health Center for Nipah Research and Resilience, we are trying to make it a center of excellence. So we planned a library, public health library, and we created a digital library. It's just like a Wikipedia thing, and our epidemiologists downloaded nearly 200 articles, and we created a common platform in the same way of Wikipedia, and actually it came very nice, and we are missing some articles which need some copyright, and I am also trying to add it as links, and I wish to just project it, but I think we will do it last.
So I think Anish has already told everything about the outbreaks over, but still, out of curiosity, I am asking. We don't know the real link. We know that virus is there in the bats. Virus is secreted when the bats get disturbed, or when the bats are pregnant, all sorts of things we hear. And we don't have Dept swab. And we know the virus is very similar that has detected in bats and humans in Kerala. So when can we expect the next step, or is it possible to prevent? Or what is the link? What could be the link? I don't know. We didn't see anything in fruits or anywhere. And no animal was seen inhabiting this virus also at the time of outbreak. So it's a question. And sometimes one case happens when we interact with the relatives, especially parents, they deny that we are creating some diseases. It's not Nipah, like that. Even that was told by parents. My son never had such things. Why did you put him on all those things? And we are now suffering. So what can we tell to the public as well?
It is a very difficult question to answer. Based on evidence, there could be three reasons or three ways by which you can be infected by a Nipah virus. One is through your nose. That means the virus is getting exposed to nerve fibers, maybe through nose. So that is, one thing is you are very close to a Nipah roost. And there is maybe many bats are positive. And there is an aerosolation. Aerosols are there in their area. So it is not an airborne disease, rather it is a droplet mediated disease where you are getting directly infected. That is one possibility. Because to support that, many places where there is Nipah spillover happened, while you are visiting, you will see that area, the presence of bats are very high in that area compared to the other areas. For example, in 2019 outbreak, that boy was living in an area where there is inside or maybe the under part of a bat roost. Even in our Palakkad, the patient is residing in an area where, so that kind of a proximity is there. Second possibility, people used to tell it is through food. Just like it is basically because of date palm sap, and it is because of fruits theory and all. But to prove this, some scientists fed this Syrian hamsters with date palm, and they just got the autopsy done, and they found that it is not the intestine or stomach, but while it is given or drinking that pap is getting exposed to the upper part of your nose. Just like your amoebic meningitis is going to affect olfactory area, the similar way, the food. If you are getting a fruit, maybe directly fresh from a bat-eaten fruit, while you are eating the fruits, inside your mouth there is an aerosolation is happening and your nerve fibers are infected. That is other way. It is not another possibility that it is going inside and it is coming through your stomach. There is no possibility because there is acid and a lot of things. And third one is an intermediate host. Any animal can act as an intermediate host. So still, sometimes there are different ways. All these three ways may be acting. First case may be act because of an intermediate host. Second case may be aerosolation. Third case may be eating a fruit or something like that. That may be the reason sometimes you may not be able to get a pattern. Anywhere in the world, any of the fruits in natural setting, even date palm sap in the natural setting was not found to be positive for Nipah. Date palm sap were positive because we infected date pumps up artificially and kept in refrigerator, then only we know that maybe after 2 or 3 days also the virus is positive. But in Bangladesh, even in Bangladesh, a date pump sap is not found to be having virus. That was never reported. So that is actually an enigma that we do not know. And the second part of your question, ma'am, when it is going to happen, it may be just like Dr. Naveen was mentioning, April to September, because our first case was reported in May 1st. If the Sabbath is the first case, it is May 5th is the death of that patient. So the transmission might have happened in April because it is early week of May. So April is also. Otherwise, we do not have a single case in April, but we have got cases in early weeks of May. That means transmission has happened in April. That is why April is there. April to September, all the 10 spillovers happened in April to September. April to September has got a lots of importance. One is the breeding season of bats. All seasonal fruits in Kerala is active. From start with mango and end with maybe the arecanut. So arecanut has got 2 seasons and second season in September. So fruity season is there. And where it is going to happen, that is also we do not know. But if you just follow the pattern, it is going towards south. Now it has reached maybe Palakkad, and we are maybe if that is a pattern. But we have got a case that in 2018 it is Maridwangara Kuttiyari area, and again it is revisited after 5 years. Every year, almost 1/4 of the bat roost is replaced by youngsters. That means if some bats are protected because of the antibodies, it will take a few years. Again, it can infect. So a bat roost can infect again and again in a period of 4 to 5 years. So we may expect again a case in Calicut because 3 years has already passed.
Thank you. And Anitha, you have already told TrueNat and PCR. So and all of us are familiar with samples. So how to send samples? We need separate samples. We all know that we should send for blood and CF. More we should do when we send samples.
When it is for TrueNat, you have to send samples in viral lysis medium. It is VLM. And if it is for RT-PCR, then you have to send in viral transport medium. That is very important. You cannot use the VLM for RT-PCR and you cannot use the VTM for TrueNat. Because once you have a lysis medium there, the precautions you need to take for doing TrueNat is less. But if there is no lysis medium, then the virus is there intact. So you cannot just handle with the sample as you handle for a TrueNat case. So that issue happens. So you should see that if you are wanting a TrueNat and immediate emergency report, you have to send the sample in VLM. With VTM sample, we won't be able to do a TrueNat test.
That is very important. We have to send samples for in viral lysate medium, and this also makes challenges. We have to wait for the next sample, or one sample has come in critical hours, late night, waiting for the sample. Create stress.
You can send simultaneously,
and giving the results and report. So Anoop was there as a doctor in the first outbreak in BMH, in the second outbreak of Calicut in Aster, and somebody was asking, is there another Anoop critical care in Aster also? So I told it is the same Anoop. So Anoop, you already discussed many of the presentations, and we also know that, I remember our Sujit was telling, when I cut the lung, I knew that this is the lungs that we first autopsy. So even our body has got the sense detecting earlier, but you have already discussed the typical clinical presentation. And also listed doses and all segment clonus. But how early? Anish has told that if the transmission happens, patient is really sick. So how early we can suspect? So you told that it's AS, ARDS, and myocarditis combinations and all those things. How early we can really suspect?
It's basically like easy to screen for Nipah for all AES cases in our area. So that is what we practice in our ICU nowadays. Yesterday also we had an encephalitis case of Lai. So she presented with 3 days history of upper respiratory symptoms, high grade fever, chill. Then yesterday morning she developed seizures, then became drowsy and so nowadays whenever such patients are coming to the emergency department, immediately we'll take all the precautions. Then only we'll take the CT, then shift to the ICU. And in the ICU, first we'll take a throat swab, do a Truna test. We'll wait for the report. If it is negative only, we'll go with other invasive procedures and other tests. So that I think that is the best way to pick up more cases. At the same time, as I told, the clustering, the clinical features, and detailed history taking, detailed clinical examination, and obviously the MRI findings. Even this time, when I was talking to the few doctors in West Bengal, that is how they picked it up. So one male nurse and one nursing staff, female nursing staff was admitted with features of encephalitis. They got ventilated because of low sensorium, not because of ARDS. Then they were taken up for an MRI. From that MRI suit, the radiologist suspected that it may be a Nipah. Then later on they sent the samples. And initially it was thought it is a part of outbreak and these healthcare workers were infected probably during handling some patients. But they couldn't identify any such infected cases before.
Yes,
They were supposed to be the direct cases because of these palm sub consumption.
Yes, very, very important message. High index of suspicion always saves, but we are doing AES surveillance, ARDS surveillance started. Hope we will do able to pick up the first case itself. Okay, first case and the index case, it will be the same. And I will ask Shamir only one thing. What will be the stress among the healthcare workers handling Nipah? Because he was the person maximum tortured. So he will be able to give the real feel of what happens really in the hospital, inside the hospital. And what more you would expect him to prepare?
It's really a big stress, as Madam was telling, for everyone, from the Health Minister or Chief Minister to the cleaning staff. Everyone was under the real stress. And from my personal point of view, I have never faced such a stressful situation in my life, throughout my whole life, in my medical or non-medical, whatever it may be. I can't even imagine the period, the months which we went through in 2018. But as I was mentioning in my talk also, so we have progressed, we have moved forward a lot. And now, that time we didn't even know what is PPE. That was the fact. We were requesting for PPE to everyone. We were sending letters to get PPE. And finally the PPE came and we didn't know what to do with this. That was the real situation. So we are fighting with an enemy which we don't know. We are hearing for the first time. How to fight, we don't know. What are the war? We don't have anything. We don't know anything, and we are still fighting. That was the situation. So we didn't know what will happen also. So all of us still here to talk about this thing. Even this thing itself is a great, എന്താ പറയുക, അത്രയും ഒരു ലോകാത്ഭുതങ്ങൾ. It's a miracle because I was one among the person who was exposed to the first patient. I was the duty on this May 5th. May 5th, the date I will never forget, because the patient expired and Dr. Anoop, they started all screening and detecting everything. And finally we were going back and seeing the duty list, who was on duty on this day. And unfortunately I was the person. And from that day till 21 days, we were every day counting the day and whether I am having fever. Every morning I will touch like this. And 2 or 3 times I got fever. This time also I don't know. This last patient also I was tested. I will be one of the health workers who was tested maximum. ഈ പ്രാവശ്യത്തെ പേഷ്യൻറ്റിലും I got a fever and few days I was in isolation. But what I learned now is, as the time went on, as we have passed few years, now we know what is PPE. Anitha madam, thanks to Anitha madam and all the microbiology department, we know how to wear PPE. And as Anish sir was telling, even a simple mask is enough. That's a very big message. And we have something. Even last time, Dr. Vineet, he went and inspected a patient in Maitra Hospital who expired. Vineet, I was talking to Vineet. Vineet went to quarantine, and what he told me was, suppose I develop a fever or something like that, and if I am tested positive, you immediately give me monoclonal antibody. So that was his message to me. So I told, don't worry, I am there. We are ready with monoclonal antibody, and we have confidence on. So we have some new agents, and we are saving patients. We are seeing patients alive after all this management. So I think we are well equipped now. We have confidence. So the stress factor has come down significantly, and now I can confidently otherwise when we ask our JRs to enter, it was but now we all go together and we see the patient and we come back. Last meeting when we managed Nipah in 2018, we won't sit like this because we have already entered the isolation ward. So we will talk only on phone. We will never attend any public meeting. We will go and we won't attend. Nowadays, we see the patient, Nipah patient, we enter the isolation ward. We don off the PPE. We go to principal's office. We talk to everyone. We go and see other patients. So it's just a casual. I won't stop. Okay.
Thank you. And I think we have taken some important questions also. And if there are any quick comments or anything, we will listen. Otherwise, we'll hand over the mic to the organizers. And it was nice interacting with everyone. And it is giving more strength as we start understanding about this disease, as we know how to manage this disease. And we are getting more equipped with regard to the tests, treatment, and the support that we offer to the healthcare workers. Everything is working together, and ultimately it's a teamwork. And the teamwork, at the end of the day, it gives a lot of happiness. Once we get over the crisis, it gives us a lot of happiness because we all could do something together. So that is very important. And every person working in, starting from the cleaning staff, lab technician, drawing blood, everybody is putting their 100%, and everyone has to be in full PPE. If there is a breach of PPE, it's a problem. And as emphasized, yesterday we had a meeting on tuberculosis, how to reduce the disease burden. So I was telling, Nipahkku mumbum കോവിഡിന് മുമ്പും ഡോക്ടർമാർക്ക് പൊതുവെ നമുക്ക് അസുഖമൊന്നും വരില്ല അല്ലേ. ഷൂട്ടം പോസിറ്റീവ് TB വന്നാലും wear mask. And even today we have that to a little bit. But at least when we deal with respiratory infections, when we are seeing patients in a critically ill ward, because a COPD patient, we don't know what is the respiratory infection that person is coming this time. So it is better that we go back to some good habits like using mask, and don't forget the hand washing and other things that we used to do very religiously during. So this all will help us, and I think if there are no quick comments from anyone, we will. Okay.
ഇന്റർസെക്ടറൽ കോർഡിനേഷന് പ്രാക്ടിക്കലായിട്ട് എങ്ങനെയാണ് ചെയ്യണത്? അതർ സെക്ടേഴ്സിന് അവരെ എങ്ങനെ, അവരുടെ കോൺട്രിബ്യൂഷൻ അവരെ എങ്ങനെ, ഇപ്പോൾ അനിമൽ ഹസ്ബൻഡറി അങ്ങനത്തെ അല്ലേ, തദ്ദേശ സ്വയംഭരണ വകുപ്പ്, പ്രാക്ടിക്കലായിട്ട് നമ്മളെങ്ങനെയാണ് ഒരു നിപ്പയുടെ ഔട്ട് ബ്രേക്കിൻ്റെ സമയത്ത് മാത്രമാണോ അതോ നമുക്ക് അല്ലാണ്ടൊരു അഡ്മിനിസ്ട്രേറ്റീവ് പ്രോട്ടോക്കോൾ ഉണ്ടോ?
ഔട്ട് ബ്രേക്ക് സമയത്ത് ഡെഫിനറ്റ്ലി ഉണ്ട്. കാരണം കേരളത്തിൽ വൺ ഹെൽത്ത് എന്ന് പറഞ്ഞ ഒരു പ്രാക്ടീസ് തുടങ്ങിയത് തന്നെ, അന്ന് വൺ ഹെൽത്ത് എന്നുള്ള പേരില്ല. 2018 നിപ്പയുടെ സമയത്താണ് കേരളത്തിൽ ആദ്യമായിട്ടൊരു വൺ ഹെൽത്ത് ആക്ടിവിറ്റി നടക്കുന്നത്. 10-25 ഡിപ്പാർട്ട്മെൻറ്റുകൾ ഒരുമിച്ച് ചേർന്നിട്ടാണ് നിപ്പ കൺട്രോൾ ചെയ്യുന്നത്. പിന്നീട് അതിനൊരു ചെറിയ മോഡിഫിക്കേഷൻസോട് കൂടിയാണ് പിന്നീട് നടന്നുകൊണ്ടിരിക്കുന്നത്. അപ്പോൾ ഔട്ട് ബ്രേക്കിൻ്റെ സമയത്ത് ഒരു റിയൽ വൺ ഹെൽത്ത് ആക്ടിവിറ്റിയാണ് നടക്കുന്നത്. അനിമൽ ഹസ്ബൻഡറി, ലോക്കൽ സെൽഫ് ഗവൺമെൻറ് എല്ലാവരും ഉണ്ട്. പക്ഷേ പീസ് ടൈമിൽ വൺ ഹെൽത്ത് നമ്മളിപ്പോൾ ഒരു കമ്മ്യൂണിക്കബിൾ ഡിസീസ് കൺട്രോളിനുള്ള ഒരു പ്രധാനപ്പെട്ട സ്ട്രാറ്റജി ആയിട്ടാണ് യൂസ് ചെയ്യുന്നത്. We are not having an One Health activity dedicated for Nipah. Rather that we are conducting some maybe Nipah Sadas or something like that, where we will just call the people from animal husbandry and all other things. But government's One Health program is for the entire list of communicable disease, basically to prevent dengue, leptospirosis, because those are very common things. But that will act for Nipah also. That is the, basically we have got a One Health approach for preventing communicable disease, and Nipah Center we are doing some activities specifically for Nipah because it is more clustered around the northern Kerala, around Calicut.
നമുക്ക് എക്സ്പെക്ട് ചെയ്തൂടെ?
അതെ അതെ.
അപ്പൊ അങ്ങനെയുള്ള ഒരു ടൈമിന്റെ തൊട്ട് മുമ്പ് തൊട്ട് നമ്മൾ അങ്ങനത്തെ ആക്ടിവിറ്റി എന്തെങ്കിലും
we have got a Nipah calendar published as a government order. അപ്പോൾ ആ ആക്ടിവിറ്റീസ് ചെയ്യുന്നത് DHSന്റെ സൈഡിൽ നിന്നാണ്. അതിനകത്ത് തന്നെ നോർത്തേൺ കേരളയ്ക്കും സതേൺ കേരളയ്ക്കും രണ്ട് കൈൻഡ് ഓഫ് സ്ട്രാറ്റജീസ് ആണ്. നോർത്തേൺ കേരളയിൽ കുറച്ചുകൂടെ Nipah സെൻട്രിക് ആക്ടിവിറ്റീസിന് കുറച്ചുകൂടെ പ്രാധാന്യമാണ്. ദാറ്റ് ആക്ടിവിറ്റീസ് ആർ ഗോയിങ് ഓൺ ഇൻ ദ ഫീൽഡ്.
ഇറ്റ് വാസ് എൻ എക്സലൻറ്റ് ഡിസ്കഷൻ. ഞാൻ എൻ്റെ ഒരു എക്സ്പീരിയൻസ്, ഞാൻ ഫീൽഡിൽ ആ സമയത്ത് വർക്ക് ചെയ്യുന്ന ഒരാളായിരുന്നു. അപ്പോൾ ഫസ്റ്റ് ഞാൻ ആ സമയത്ത് CHC നെടുവ പരപ്പനങ്ങാടി വർക്ക് ചെയ്യാണ്. അപ്പോൾ നമ്മുടെ HSC വിളിച്ചിട്ട് പറഞ്ഞു, സാർ ഒരു ന്യൂമോണിയ ഡെത്ത് നമ്മുടെ അടുത്തുള്ള മൂന്നിയൂർ ഭാഗത്ത് വന്നിട്ടുണ്ട്. അപ്പോൾ സാർ അവിടെ ആ ഫീൽഡ് ഒന്ന് വിസിറ്റ് ചെയ്യണം, പബ്ലിക് ഹെൽത്ത് ഇൻവെസ്റ്റിഗേഷൻ കണ്ടക്ട് ചെയ്യാൻ വേണ്ടി പോകണമെന്ന് പറഞ്ഞു. അപ്പോൾ ഞാൻ പിറ്റേ ദിവസം രാവിലെ ആസ് യൂഷ്വൽ, ഇപ്പോൾ നമ്മളൊരു PPI ഒന്നും ഇല്ലാതെ ആസ് യൂഷ്വൽ പോയി. അപ്പോൾ നമ്മൾ നോക്കുന്ന സമയത്ത് അത് നമ്മുടെ ഇൻഡെക്സ് കേസിനോട് പിന്നെ റിലേഷനുള്ള സിന്ധു എന്ന് പറഞ്ഞൊരു പേഷ്യൻ്റ് ഉണ്ട് അല്ലേ, മരിച്ച സിന്ധുവിൻ്റെ വീടായിരുന്നു. അപ്പോൾ അത് മേലെ ഒരു 2-3 വീടുകളാണ് ആ മൂന്നീര് ഭാഗത്ത് 3-4 വീടുകളായിട്ട് അടുപ്പിച്ചുള്ള കോളനിയാണ്. അവിടെ അപ്പോൾ ആ സമയത്ത് അവിടുത്തെ MLA വന്നിട്ടുണ്ട്, മറ്റേ ആളുകൾ വന്നിട്ടുണ്ട്. അവിടെ ഒരു ക്യാമ്പ് പോലെയാണ് അവർ കണ്ടക്ട് ചെയ്യുന്നത്. അപ്പോൾ ആ ക്യാമ്പിൻ്റെ ഉദ്ദേശത്തിൽ എന്നെ വിളിച്ചിരിക്കുന്നത് അവിടെ ഒരു ക്യാമ്പ് നടത്താനാണ്, അവിടുത്തെ എല്ലാ കുട്ടികളെയൊക്കെ നോക്കുന്ന ക്യാമ്പ് നടത്താൻ. അപ്പോൾ ഞാനത് കഴിഞ്ഞിട്ട് അതോടൊന്ന് ആ സിന്ധുവിൻ്റെ മക്കളെ നോക്കി, അത് കഴിഞ്ഞ് ബാക്കി ഇവരെല്ലാവരെയും നമ്മൾ നോക്കി, ആ സാധനങ്ങളൊക്കെ നോക്കി. അപ്പോൾ ഞാൻ പറയുന്നത് വെച്ചാൽ നമ്മുടെ ആ അവയർനെസ്സിൻ്റെ സമയത്ത് ആ ഇൻഡെക്സ് കേസുകളുടെ ആ സമയത്തുള്ള ഒരു എക്സ്പീരിയൻസ് പറയുന്നതാണ്. പിന്നെ അതുപോലെ പിന്നെ സരിത മാഡം പറഞ്ഞ പോലെ തന്നെ വെച്ചാൽ അന്ന് ഞാൻ IAP കോഴിക്കോടിൻ്റെ സെക്രട്ടറി ആയിരുന്നു. അപ്പോൾ സരിത മാഡം അന്ന് നമ്മുടെ കൺട്രോൾ റൂം വന്ന് കാണാൻ വേണ്ടിയിട്ട് പറഞ്ഞു. അന്ന് നവീൻ പബ്ലിക് ഹെൽത്തിലേക്ക് വരികയാണ്. അപ്പോൾ നവീൻ എന്നോട് പറഞ്ഞത് ഞങ്ങളും വരുന്നുണ്ട്. അപ്പോൾ നവീനായിട്ട് മാഡത്തിൻ്റെ അടുത്ത് പോയ ഒരാൾ എന്നുള്ള നിലയിൽ അത് പറയുന്നു. നമ്മൾ അന്ന് നമ്മുടെ കണ്ടുപിടുത്താണ് നവീൻ. അപ്പോൾ നവീൻ അതിനുശേഷം നല്ല ഉയരങ്ങളിലേക്ക് എത്തി. നവീൻ അതിൻ്റെ ഒരു മുതൽക്കൂട്ടായി. ഇപ്പോൾ നവീനും നമ്മുടെ ഈ നിപ്പ ഹെൽത്ത് സെൻറ്റർ ഇത്രയൊക്കെ എത്തിയാലൊരു അഭിമാനവും കൊള്ളുന്നു. എല്ലാവർക്കും നന്ദി.
വേറെ ആർക്കെങ്കിലും എന്തെങ്കിലും ക്വസ്റ്റ്യൻസ് ഇല്ലെങ്കിൽ we move on to the felicitation of the speakers. First, may I request Dr. Madhavan.G.R sir to hand over a token of appreciation and love to Dr. Chandni. I request our dear Dr. Sarita Madam to present the memento to Dr. Anish TS. Thank you, Madam. May I now request Dr. Thomas Bina Madam to present the memento to Dr. Anitha PM. I request Dr. B. Venugopalan, sir, to present the memento to Dr. Anoop. I request Dr. Sandhya Madam to present the memento to Dr. Shamir. Dr. Ranjith to hand over the memento to Dr. Naveen.
സ്നേഹം നിറഞ്ഞ ചാന്ദിനി മാഡം, ഇന്നത്തെ പാനലിസ്റ്റ് എല്ലാവരും വളരെ ഭംഗിയായി, വളരെ ഗംഭീരമായി നമുക്കുള്ള നല്ലൊരു ഇൻഫർമേറ്റീവും യൂസ്ഫുള്ളായിട്ടുള്ളൊരു ടോപ്പിക്കാണ് ഇവിടെ ഡിസ്കസ് ചെയ്തത്. നമ്മളങ്ങനെ അത് മുന്നോട്ട് കൊണ്ടുപോകണം. നമ്മുടെ ക്ലിനിക്കൽ സൈഡിൽ നമ്മങ്ങനെ പോകണം, റിസർച്ച് സൈഡിൽ എങ്ങനെ പോകണം, എല്ലാം നമുക്ക് ഡീറ്റെയിൽ ആയിട്ട് ഓരോരുത്തരും പറഞ്ഞു തന്നു. ഇതിൻ്റെ ഏറ്റവും ഒരു പ്രത്യേകത എന്ന് പറഞ്ഞാൽ നമ്മുടെ എല്ലാം കണ്ണ് നിറഞ്ഞ് മനസ്സ് നിറഞ്ഞ ഒരു ടോക്കാണ്. പിന്നെ ഒരു എക്സ്പീരിയൻസുകളുടെ ഒരു ഒഴുക്കായിരുന്നു. അപ്പം ഇപ്പോഴും ഞാൻ ഓർക്കുന്നുണ്ട് ആ ഒരു ടൈമിൽ നമ്മുടെ ഡോക്ടർ ഷമീറിൻ്റെ എഴുത്തുകൾ, അതായത് ഭയങ്കര ടച്ചിങ് ആണ്. നമ്മൾ വേറെ പെരിഫറൽ ഇൻസ്റ്റിറ്റ്യൂഷനിൽ നിന്നിട്ട് ഓരോ ദിവസം എന്താണ് സംഭവിക്കുന്നത് അതിൻ്റെ ആ പോയിൻറ്റ്സും കാര്യങ്ങളെല്ലാം ഭയങ്കര ടച്ചിങ് ആയിട്ട് ഡോക്ടർ ഷമീർ എഴുതുകയും ചെയ്യും, പബ്ലിക്കിന് അറിയാനും പറ്റും. പിന്നെ ഉള്ളത് നമ്മുടെ മിനിസ്റ്റർ, നമ്മുടെ DHS. ഞാനിങ്ങനെ ആലോചിക്കും, മാഡം ആ പോസ്റ്റിലെല്ലാം ഇരുന്ന സമയത്തുണ്ടായിരുന്ന ആ ഒരു സ്ട്രെസ്സും ഇതെങ്ങനെ ഒരു കാറ്റത്തിട്ട പോലെയാണ്, ശൂന്യതയിലായിരുന്നു. അപ്പം മാഡം, നമ്മുടെ മിനിസ്റ്റർ ശൈലജ ടീച്ചർ, പിന്നെ ചാന്ദിനി മാഡം, പിന്നെ ഡോക്ടർ നവീൻ, എനിക്ക് പറയണ്ട, ഡോക്ടർ അനൂപ്, ആരുതെന്ന് പറയണ്ട, ഡോക്ടർ അനീഷ്, പിന്നെ അനിത മാഡത്തിന് നിപ്പ അല്ലാതെ നമ്മുടെ കോവിഡ് വന്ന സമയത്ത് എപ്പോഴും കോണ്ടാക്ട് ചെയ്യാറുണ്ട്. എന്തായാലും നമ്മുടെ ദൈവങ്ങളാണ് എന്ന് തന്നെ വേണമെങ്കിൽ നമുക്ക് ഈ ഒരു കാര്യത്തിന്, നമ്മുടെ കേരളത്തിന്, ലോകത്തിന് മാതൃകയായ ഈ ഒരു നിപ്പ മാനേജ്മെൻറ്റ്, അതിൻ്റെ ടീം, ആ ഒരു ടീം സ്പിരിറ്റോട് കൂടി അവനവൻ്റെ ഹെൽത്ത് നോക്കാതെ റിസ്ക് ഏറ്റെടുത്തുകൊണ്ട് നമുക്ക് വേണ്ടി പ്രവർത്തിച്ച എല്ലാ ഡോക്ടേഴ്സിനും, ഇതിപ്പം നമ്മുടെ ഇവിടെയുള്ള പാനലിസ്റ്റ് മാത്രമാണ്, നമ്മുടെ മെഡിക്കൽ കോളേജ് ഡിപ്പാർട്ട്മെൻറ്റ് ഡോക്ടർ തുളസീധരൻ HOD ആയിരുന്നു, സാറായിരുന്നില്ല ആ സമയത്ത് HOD, അതിൻ്റെ താഴെപ്പെട്ട എല്ലാ ക്ലീനിങ് സ്റ്റാഫ് തുടങ്ങി എല്ലാ പൊസിഷനിലുള്ള എല്ലാ വർക്കേഴ്സിനെയും, ഇതിനു വേണ്ടി പിന്നിൽ പ്രവർത്തിച്ച എല്ലാ വർക്കേഴ്സിനെയും ഈ ഒരു നിമിഷം ഓർമ്മിക്കുകയാണ്. പിന്നെ നമ്മുടെ മരിച്ചുപോയ നമ്മുടെ ആരോഗ്യ പ്രവർത്തക ലിനിയെയും കൂടി ഈ ഒരു നിമിഷം ഓർക്കുകയാണ്. എന്തായാലും നല്ലൊരു പരിപാടി, മനസ്സ് നിറഞ്ഞൊരു പരിപാടി. നമുക്ക് എല്ലാവരോടും ഒന്നും കൂടി താങ്ക്സ്. ഇതിൽ ഏറ്റവും ഒരു കാര്യം മറന്നുപോയി, നമ്മുടെ ജിതിൻ, അതായത് CGPയുടെ എല്ലാമാണ് ജിതിൻ. കഴിഞ്ഞ ലാസ്റ്റ് 2 years ആയിട്ട് നമ്മുടെ കോഴിക്കോട് IMAക്ക് ഡോക്ടർ ബേബി സുപ്രിയയുടെ ഒന്നിച്ച് കോഴിക്കോട് IMAക്ക് നാഷണൽ അവാർഡ് വാങ്ങിക്കൊണ്ടിരുന്ന ഡോക്ടറാണ്. ഈ ഒരു ഡോക്ടർ ആണ് ഈ ഒരു എന്താ പറയേണ്ടത്, ഫോറൻസിക് സർജൻ ആയിരുന്നത്, ഫസ്റ്റ് പേഷ്യൻറ്റിൻ്റെ ഫോറൻസിക് സർജൻ ആയിരുന്നത് എന്നുള്ളത് വളരെ ഒരു എന്താ അഭിമാനമുള്ളൊരു കാര്യമാണ്. പക്ഷെ ഇന്നാണ് അറിഞ്ഞത് അതെന്തുകൊണ്ട് എന്നുള്ളത്, ഇപ്പോഴും ഇങ്ങനെ ഒളിഞ്ഞു കിടക്കും. എന്തായാലും ഇവിടെ എത്തിച്ചേർന്ന എല്ലാവർക്കും, എല്ലാ IMA മെമ്പേഴ്സിനും താങ്ക്സ് പറയാണ്. അവർക്കൊന്നും ഒഫീഷ്യൽ വോട്ട് ഓഫ് താങ്ക്സിന്.
എല്ലാവർക്കും നമസ്കാരം. സാധാരണ നേരെ വോട്ട് ഓഫ് താങ്ക്സിലേക്ക് പോകാറാണ്, പക്ഷേ ഞാൻ 1 മിനിറ്റ് നിന്ന് എടുക്കുകയാണ്. ഒരു 2018 ഞാനിപ്പോൾ ഫോറൻസിക്കുമായിട്ട് തന്നെ ആക്ച്വലി യാതൊരു ബന്ധവുമില്ല. കഴിഞ്ഞ ഒരു 6 കൊല്ലമായിട്ട് പബ്ലിക് ഹെൽത്ത് ഒരു അസിസ്റ്റൻറ്റ് ഇൻഷുറൻസ് മെഡിക്കൽ ഓഫീസറായിട്ടാണ് വർക്ക് ചെയ്യുന്നത്. പക്ഷെ ഒരു 7 വർഷം ബാക്കിലേക്ക് പെട്ടെന്ന് പോവുകയാണ്. ആ ഒരു 10-15 ദിവസം ഇന്നും മറക്കാൻ സാധിക്കില്ല. ഷമീർ സാറിൻ്റെ അന്നത്തെ എഴുത്തുകളിൽ ഏറ്റവും കൂടുതൽ ഹൃദയത്തിൽ തട്ടിയൊരു വാക്കാണ് മരണഭയം. അത് എല്ലാവർക്കും ഒരുപോലെയാണ്. ഞാൻ ആവർത്തിച്ച് ചിന്തിക്കാറുള്ളൊരു വാക്കാണ്. പലപ്പോഴും നമ്മൾ വളരെ കാഷ്വലായിട്ട് പറഞ്ഞു പോകുന്നൊരു വാക്കാണ്, പക്ഷേ അതിൻ്റെ ഒരു ആഴം ശരിക്കും ഫീൽ ചെയ്ത 10-15 ദിവസങ്ങളായിരുന്നു അന്ന്. അത് സാധാരണ നമ്മൾ ഫോറൻസിക്കിൽ വരുന്ന 99 പോസ്റ്റ്മോർട്ടംസും മെഡിക്കൽ ലീഗൽ ഓട്ടോപ്സി ആയിരിക്കും. പക്ഷേ അന്ന് അതൊരു പെത്തോളജിക്കൽ ഓട്ടോപ്സി ആയിരുന്നു. നമ്മുടെ പെത്തോളജി പ്രൊഫസറായ രാജീവൻ സാറായിരുന്നു അന്ന് അതിൻ്റെ ചാർജ്. അപ്പം സാറിന് വേണ്ടി ഡിസെക്റ്റ് ചെയ്യുക എന്നുള്ളൊരു ചാർജായിരുന്നു എനിക്കുണ്ടായിരുന്നത്. ഇന്നും ജീവിതത്തിൽ ഫോറൻസിക്കിൽ ഒരു 400-450 കേസ് ചെയ്തതിൽ ഇതുപോലത്തെ ഒരു ARDS ലങ്ങ് കണ്ടിട്ടുണ്ടോ സംശയമാണ്. അത് ഒരു ഫോറൻസിക് പരമായിട്ടാണെങ്കിൽ നമ്മൾ ചെയ്യുന്നതിനേക്കാളും ഡീറ്റെയിൽ ആയിട്ട് രാജീവൻ സാർ ഒരു പെത്തോളജിസ്റ്റ് ആയതുകൊണ്ട് സാറ് സൈഡിൽ നിന്ന് എങ്ങനെ അതിനെ ഡിസെക്റ്റ് ചെയ്യണമെന്ന് ഇൻസ്ട്രക്ട് ചെയ്ത് തരുമായിരുന്നു. ഒന്നുമില്ല, ഒരു വളരെ സിമ്പിളായിട്ടുള്ളൊരു പ്ലാസ്റ്റിക് ഏപ്രൺ, ഒരു സിംഗിൾ മാസ്ക്, ഇത് മാത്രമായിരുന്നു വേഷം. ഒരു 1-1.25 മണിക്കൂർ ആ ബോഡിയായിട്ട് വളരെയധികം കോണ്ടാക്റ്റ്. ആ ARDS ലങ്ങായിട്ട് തന്നെ 15 മിനിറ്റ് കോണ്ടാക്റ്റ് ഉണ്ടായിരുന്നു. അടുത്ത ദിവസം തൊട്ട് പേപ്പറിൽ ന്യൂസുകൾ വരുന്നു. ഒരു രീതിയിലും ജീവിതം മുന്നോട്ട് പോകുമെന്ന് തോന്നിയിട്ടില്ല. കോക്ടെയിൽ വരെ റെഡിയാക്കി നോക്കി വെച്ചിട്ടുണ്ടായിരുന്നു, ഒരു പനിയോ മറ്റോ പനിച്ചു കഴിഞ്ഞാൽ, കാരണം ബാക്കിയുള്ളവർ ബുദ്ധിമുട്ടിക്കണ്ടല്ലോ. പക്ഷേ എങ്ങനെ ഒരു പനി പോലും വരാതെ ആ ഒരു കാലഘട്ടം കടന്നുപോയി. നേരത്തെ അനീഷ് സാറ് പറഞ്ഞ പോലെ ഒരു സിംഗിൾ സർജിക്കൽ മാസ്ക് ആണെങ്കിലും ഇറ്റ് ഈസ് വെരി വാല്യുബിൾ. അതിൻ്റെ ഒരു ശക്തി മനസ്സിലാക്കിയ ഒരു സമയം കൂടിയായിരുന്നു അത്. അതുപോലെ ഷമീർ സാറിൻ്റെ എഴുത്തുകളും അന്ന് നമുക്ക് ഏറ്റവും അധികം കൺസോളിംഗ് ആയിട്ടുള്ള ഒരു ഘടകവുമായിരുന്നു. അപ്പം ഇന്ന് ഈ പ്രോഗ്രാമിന് ഇത്ര ഭംഗിയായിട്ട് ഇവിടെ മോഡറേറ്റ് ചെയ്ത ചാന്ദിനി മാഡം, അതുപോലെ നമ്മളോട് അസോസിയേറ്റ് ചെയ്ത കേരള വൺ ഹെൽത്ത് സെൻറ്റർ ഫോർ നിപ്പ റിസർച്ച് അതിൻ്റെ നോഡൽ ഓഫീസറായ അനീഷ് സർ, ദെൻ നവീൻ സർ, അനൂപ് സർ, ഷമീർ സർ, അനിത മാഡം, എല്ലാവർക്കും എൻ്റെ പേരിലും IMA പേരിലും IMA CGPയുടെ പേരിലും ഞാൻ നന്ദി അറിയിക്കുന്നു. പിന്നെ നമ്മുടെ IMA ലീഡേഴ്സ് സന്ധ്യ മാഡം, രജിത്തേട്ടൻ, എൻ്റെ സ്വന്തം അസിസ്റ്റൻറ്റ് ഡയറക്ടർ നൗഫ്ര മാഡം, ഇന്നിവിടെ എത്തിയ ഓഡിയൻസ്, നമ്മുടെ എല്ലാ യൂട്യൂബ് വ്യൂവേഴ്സ്, എല്ലാവർക്കും നന്ദി പറഞ്ഞുകൊണ്ട് അവസാനിപ്പിക്കുന്നു. നന്ദി, നമസ്കാരം.